Live now, ma'am.
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shiru Connect, welcoming you all for today's webinar, Understanding Endometriosis and Adenomyosis, the Mysterious Invader, organized by TNFOG, Foxy No to Wow Committee, and Mumbai OBGYN Society and Northwestern Societies. So it's my privilege to introduce the convener of today's webinar, Dr. Jairani ma'am. Ma'am is currently the Joint Secretary of TNFOG, past President of OXY, and also Vice President of TAPISAR, South Zone Coordinator for Foxy No to War Committee, Associate Secretary for World Association for Sexual Health, Advisory Council member.
Thank you, Sagati. Thank you.
I welcome you, ma'am, and I hand the session to you.
Thank you, Sagati. Very special thanks to all the senior faculties and a very special good evening to our chief guest, Madam Dr. Jaideep Malhotra, Madam, the guest of honors, Dr. Anjisoni, Dr. Ramani Devi, Madam, and Dr. Swarna Kadilkar, Madam, and my friends and co-conveners, Dr. Geeta and Dr. Aruna Suman, and the senior faculties from all through the country, like the great speakers, Geeta Balsarkar from Mumbai, and Subhash from Kerala, and Rekha from Bangalore, and Arun from Salem, and all the other senior faculties here. We welcome you all on behalf of TNFOG and also the No to War Committee and Mumbai OBGYN Society and the Northern Societies of Rajasthan. We welcome you on this wonderful webinar where we are going to understand the endometriosis and adenomyosis, which is a very important one, what we call as a mysterious invader in the women's body. So we are here on this endometriosis month to create an awareness about the endometriosis and how we can treat it and how we can proceed to the latest inventions. We have all the dynamic speakers here. We welcome you all for this wonderful webinar. So we'll start with the first prayer song of the Tamil Thai Valthu, which we pay tribute to the Tamil goddess. So we'll now start the knowledge with the lightning of the Kuttuvilakku, which says dispelling the darkness and creating the knowledge light in every one of us. Let's start the inauguration with the lightning of Kuttuvilakku. So we are now very honored and happy to have here our chief guest, Dr. Jaideep Malhotra, Madam. We know her such a dynamic and very charming and very motherly past president of Foxy, who was an immediate past chair of the FIGO Reproductive Endocrinology Committee and a member of accountability group of PNNCH of WHO. And she's the president-elect of INSTARC and the past president of Aspire, Foxy, IZAR, IMS, SAFOMS, and ISPAC. And Madam is the editor-in-chief of SAFOG and SAFOMS, SOFOMS, journals and many books. And she has co-edited more than 65 books and it is really amazing. And she's the regional director of the South Asia Iron School of Ultrasound and the professor of the Dubrovnik International University, Croatia, and the past secretary and vice chairman of ICOG. Madam has been various credentials, and she has been credited as the first 500 IVF babies of Nepal, the first IVF ICSI Tiza twins of UP in India, and she's been the advisor of the Maulana Abul Kalam Azad Medical College, Delhi, JNMC Aligarh, and SMC Medical College, Jaipur. Madam has initiated so many initiatives like Club 35 Plus and a Rotary Club for the Agra Group. And she has been awarded very many prestigious awards. There's a Lifetime Achievement Award of the ISSRF and ISAR, and Legends of Foxy Award in 2025, and the Aspire Distinguished Service Award, and the recipient of the Nepal Summon Award 3 times, and the recipients of the honored FRCOG and FRCP. And Madam, we welcome you, and we will be very happy to get your blessings, ma'am.
Thank you. Thank you so much, Jaya. Thank you, and a very good evening to all of you. It's such a pleasure, and I really want to thank you for all the love and affection which all of you bestow on me. It really, energizes each one of us. And it's important also that we keep on meeting, because it's something which really, exchanging knowledge and also exchanging goodies with each other. It's important because it keeps us alive. And I would really feel that, it's a great topic which you have chosen today. And endometriosis and adenomyosis all have been very, very enigmatic. Today, we do understand a lot, but I think there's a lot more which we have to actually, research and talk about. I keep on talking on this topic a lot, so it's close to my heart too, because today, like, when we go through the ASHRAE guidelines, the diagnosis, the modalities to diagnose are changing, the modalities to actually treat and manage is changing. And adenomyosis has been even more enigmatic, because when we go for, IVF, even at that time, like whether we should be putting these people on women on GnRH, well, whether it will improve the results or no, whether surgery is going to improve the results. I see that you have chosen the most difficult aspect of endometriosis and adenomyosis for discussion today. I would be very, very happy to, hear all the discussions with some lovely, great speakers who are very close to my heart. And I also know that, they are very knowledgeable. So I would really wish each and every one of you all the best. Keep on doing the good work. Keep on discussing and sharing knowledge, because it really takes us far ahead. Thank you so much for having me.
Thank you, madam. Thank you for your kind words. And it's really inspirational to get blessings from you, ma'am. Thank you so much. And we have with us Dr. Swarna, madam. Swarna Kadelkar, madam. Madam is the Secretary General of FOXI. Madam is busy with the FIGO meeting. And she's the Secretary of the MOGS 2020. And she's the Editor Emeritus of Jogi 21 onwards. Editor-in-Chief of Journal of OBGYN Jogi 2018 to 21. And she's a recognized teacher in endocrinology in the University of South Wales, UK. And she's the member of FIGO working group on post-reproductive health between 2018 and 19. And Madam is the treasurer of FOXI between 2018 and 21, and the president of the Indian Menopause Society in 2017, and the president of Association of Medical Women of India, Mumbai branch between 2011 and 16. And Madam has edited more than 12 books, more than 100 publications, and won several prizes and awards, and delivered very many orations, keynote addresses, and invited lectures on national and international platforms. Madam will join anytime at her convenience, but we are very happy to have her and her blessings. And we move on to the next guest of honor. Let me introduce my co-convener, Dr. Aruna Suman, to introduce the next guest of honor. Aruna is the professor of OBGYN and HOD of Medical College of Jagdal, Telangana, the Joint Secretary of FOXI between 21, and AACOJ Hyderabad 2024 Organizing Secretary, and the National Coordinator of the No to Work Committee, and the practical...
Thank you, Dr. Jairani.
Yeah,
thank you so much for the opportunity. My sincere thanks to TNFOG, FOXI No to Work, Mumbai OB-GYN Society, and Northwestern societies. Thank you for this opportunity. And I'm privileged to have an opportunity here. Thank you, Jaideep Madam. We are a big fan of yours for your grace and intelligence. Thank you so much. And Ramani Madam, thank you. And Sampath Kumari Ma'am, thank you so much for giving me this opportunity. My privilege, and I feel very happy to introduce graceful and very intelligent Dr. Anju Soni ma'am. She is HOD of Gynops Sony Group of Hospitals. She is President IMS 2425, Secretary General IMS 2223, Governing Council member of ICOG. She is a Vice President-elect of Foxy and member India CCM 2225, Chairperson HIV AIDS Foxy 2023. Special interest is high-risk pregnancy,
Thank you,
critical
dear.
care,
Thank
gynae,
you,
minimal
thank you,
invasive.
thank you so much for your
I welcome you, Anju ma'am. Please
for
address the gathering.
for your beautiful introduction. I'm really humbled to be introduced by my dear friends, and I'm very humbled to be here with Dr. Jaideep, who has been like mentor for lots and lots of people, and very happy to meet all of you, Dr. Ramani. Of course, Dr. Swarna would be there anytime, and all the people from my own state and the South. Very happy to be with all of you. Uh, Adenomyosis, whenever we talk about, along with endometriosis, are the two very commonly misunderstood yet significant conditions that impact millions of women worldwide. And these conditions not only cause debilitating pain, menstrual irregularity, but also contribute to infertility, as Dr. Jaideep just said, a reduced quality of life. And despite so many, research and treatments available, they are often misdiagnosed or diagnosed very, very late, leading to a prolonged suffering in the woman. And this webinar, organized by, uh, by all of you from TNFOG, Foxy, NU2, WOW, Mumbai OBGYN, and aims to shed light on these conditions by bringing the experts, Dr. Geeta, Dr. Malaya, who will discuss the latest advancements that the diagnosis, treatment strategies, and patient management. And their insightful discussions and case-based learning will definitely come out with effective strategies for managing both the problems, even in working on fertility enhancing and surgical intervention, and the complex relationship between endometriosis, infertility, and reproductive health. And by delving into the cutting edge research, clinical best practices, multidisciplinary approaches, this session will equip healthcare professionals with the necessary knowledge to improve patient care. And I would like to congratulate the organizing team for taking up such a beautiful topic. And I'm sure this will definitely engage the participants who will be able to learn and contribute a lot towards advancing and understanding management of this challenging condition. So let's come together, demystify this mysterious invader, and provide better healthcare and solution for women affected by endometriosis and adenomyosis. I'm sure today's webinar will be a great will bring great insights for each and everyone. I'm sorry I'll have to leave. I had a meeting which was there with at 8 p.m. and I'm sorry I had to I will have to leave for a while. Once I'm free from the meeting, I'll join back again. Thank you for inviting me, and best wishes for all future endeavors to Dr. Jayarani, who has been working very hard over the years, and we know how hard she is working and how knowledgeable she is in all the subjects. So my best wishes to Dr. Jayarani and Dr. Geeta for their future
Thank you,
endeavors.
madam.
Aruna, Rekha.
Ma'am, you have to
Aruna,
bless me
Aruna,
too.
Rekha.
And
Oh,
Rekha.
Aruna, Rekha, all of us are there
All
here.
of all of you. Dr.
All
Rakhi also, everybody.
All
So
love
my
to you, ma'am.
wishes to each and everyone.
Thank you so much.
Okay,
you,
bye bye.
Thank you, ma'am. Thank you.
Thank you for those inspirational words, ma'am. Thank you so much. My next convener, can I introduce Dr. Geeta Balsarkar, madam? Can I have her CV, please?
Sahiti?
Yes, ma'am. Just
Yeah,
a second,
yeah.
ma'am. I'm displaying.
We all know Madam has worked so much.
This
Can
is
I have
Ramani
Dr.
madam.
Geeta Balsarkar Madam's CV, please?
Previous one. Saiti, go one low. No.
We all know that she has worked so
Yeah,
much.
Aruna,
for
I can
jobs.
introduce myself. Yeah, not a problem. I'm a professor at the Nowruz. Yeah.
Ma'am, please let me have
Hmm.
the
Yeah.
opportunity to introduce you.
Hmm.
She's a professor and unit head, Navroji Wadia Maternity Hospital and Seth GS Medical College, Mumbai, fetal medicine consultant and teacher for MUHS Fellowship, editor-in-chief, International Journal of Infertility and Fetal Medicine, editor emeritus, Journal of Obstetrics and Gynecology of India. We all know she has done a lot of hard work. Secretary of Mumbai OBGYN of India 24-25, member of District Quality Assessment Committee for Maternal Mortality Mumbai 21 till date, chairperson Young Talent Promotion Committee 2014 to 16, conducted PPIUCD program of FOXY from 2013 to 16, former president Association of Women Medical Women in India Mumbai branch 21, former president Mumbai Menopause Society 21, recipient of prestigious Hari Gobind Foundation Fellowship for Study of Fetal Medicine in London in 2008, undergraduate and postgraduate teacher and examiner also since almost 25 years, more than 25 years, editor of various books in the subject of OB/GYN, authorized many various books and authored various books and chapters in obstetrics and gynecology. I welcome you, Dr. Geeta Balsarkar, madam. Please.
Thank you. Sahiti, can we have the next slide, please? Can I introduce Dr. Ramani Devi? Yeah, I take great pleasure in introducing Dr. Ramani Devi because I look up to her and she is my role model in many ways. You know, many conferences, many places I talk about her and how she inspires all of us to work more in our subject. So she is the President TNFOG 2024, National Vice President Foxy 2020. She's on the International Advisory Board member of Fertility Society of Bangladesh, ICOG Governing Council member 2018 to 20.
Geeta, I think Tamil Nadu people know about me. It's okay. It's okay.
Thank you,
for
madam.
your
You're really
kind
an
introduction.
inspiration for all of us.
It is for non-Tamil Nadu people, madam. She's reading.
Non-Tamil Nadu
And
people.
for not Tamil Nadu also, I have been the national vice president. It's okay. Okay.
Yes, madam.
Okay.
Madam, give us
Madam is the
blessings and
endometriosis
give us
queen.
good points, madam.
Madam is the endometriosis queen.
That
is the
PhD in endometriosis.
Okay. Okay, Jairani.
Madam.
Yeah, I think it is a great pleasure to be guest of honor for this important topic, which is very close to my heart, that is endometriosis and adenomyosis. All of you know that March is a month of endometriosis. So end March as with endometriosis, and subsequently April is going to be the month of adenomyosis. You should understand that more than 200 million women all over the world, they suffer from endometriosis, and India alone, 1/4 of the women in are found in India. That is according to the Endometriosis Society India. See, they present with varying symptoms, and the paradigm shift in starting right from the symptoms, diagnosis, clinical findings, as well as with the imaging evidences, molecular evidences for the early diagnosis of endometriosis, as well as management, and especially the management in infertility has totally changed. I think this talk by the panel discussion, as well as we should know when we should limit surgery in endometriosis. And surgery, if at all it should be done by a surgeon who is specialized in that, so that we are not reducing the ovarian reserve for infertile couple. And again, adenomyosis, I feel it is on the increase. Previously, we used to say that adenomyosis is a disease of multiparous women, but now we see adenomyotic patients even at the age of early second decade, And it is often early onset adenomyosis is often associated with endometriosis, which I always say that it is a deadly DO. And whenever a patient undergoing ART has got an implantation failure or a IVF failure, we have to think about subtle endometriosis, because correction of subtle endometriosis, when you transfer them, they do become pregnant. And again, endometriosis, the newer concept is the microbiome. Gut microbiome has got an impact upon endometriosis. So totally revamping the or normalizing the gut microbiome can also reduce the endometriotic symptoms and can reverse it. I think these are some of the points which I wanted to highlight. And today we have a very good speaker, Dr. Geeta Balsarkar, who is going to talk on adenomyosis, and subsequently followed by a good endoscopic surgeon who can provide us the skills of how to make the surgery very comfortable and surgery very clean. And again, we have great experts and the panelists and the panel moderators who are going to have, that is Rekha Rajendran and Ashwin Rao, with the panel experts, Dr. Asha Rao, who will be dealing with the case scenarios. And ultimately, I wish all the contestants for this Foxy election, Dr. Jayarani Kamaraj, Dr. Rekha Rajendran, Dr. Geeta Balsarkar, and Dr. Aruna Suman, to have a successful outcome. I pray God that you must achieve whatever you feel like in this coming Tamil New Year.
Madam
Wish
Umayal
you
is also there, ma'am. Umayal also need your blessing. Umayal is
Umayal,
also
yeah. Umayal, okay.
I was about to tell.
Adolescent committee, madam.
Umayal, madam.
Okay,
Umayal.
okay, all the best, Umayal. Umayal, all the best. Okay.
Thank you, ma'am.
Okay, okay.
Thank you, madam. Thanks.
Hi, Ramani. Good evening. Asha Rao here. You have really inspired all of us.
Both of them, both of you, ma'am, for the endometriosis.
And
Thank you, ma'am.
congratulations to Jairani in advance.
Thank you, ma'am.
We're all ready for we're all ready for the talks now.
Thank you, ma'am. Thank you. We are moving on to the academic session. Thank you so much. I thank the chief guest of honors, and all the senior faculties here. And I'm welcoming the chairperson for the first session, Dr. Khushbu Meena, who is the Associate Professor of Government Medical College of Kota. Madam is the Secretary of the Kota OBGYN Society 24-25, member of FOXY. She has graduated from SMS Medical College, Jaipur, and she is a postgraduate from PGI JMR, Chandigarh. Master trainer of Comprehensive Abortion Care Service at Regional Center, conducted labor workshop in FOXY Zonal Conference, and her area of interest is high-risk pregnancy, infertility, gynec endoscopic surgeries. We welcome you, madam, to be the chairperson. And we are very pleased and honored to have Dr. B.S. Jodha here. Sir is the Master of Surgery of DGES, Senior Professor of OBGYN from the SN Medical College, Jodhpur, Rajasthan. He had a special awards and achievements. It's the Diploma in Gynec Endoscopy from France, trained in ultrasonography, ART fetal medicine, Secretary of the Jodhpur OBGYN Society. And the sir is the master trainer, and he has a Marvelous Achiever Award of 2015. And he is a postgraduate and undergraduate examiner in various universities, and had very many papers he has done for the university exams, and he had been a review editor for journals, and he had various publications in the national and the international journals. Over to chairpersons for this first session. And we have Savita madam here. Yeah, can I have Savita madams? Yeah, we have here Dr. Savita Lalgaria, who is a OBGYN of more than 25 years of service, and she's very much served to the humanity and mankind. She's the director of the Lalgaria Hospital and at Sri Ganga Nagar, and she's the member of the Fetal Medicine, secretary of the Sri Ganga Nagar OBGYN Society, conducted very many CMEs and webinars on regular basis, as well as social welfare regarding the health, education, and checkup. And Madam is the IMA Female Wing President, and she has been awarded a Giants International Prerna Group Award, awarded by the Lions Club and many social welfare groups. Over to you, chairpersons, for the first session. To introduce the speaker.
I think Jairani, I have already been introduced. So can I start sharing my slide, please? Cherani, you're muted.
Dr. Savita is here. Madam, if she want to say about the thing, I think chairperson of the first session.
Savita ma'am, please unmute.
Dr. Savita, you can introduce Geeta Balsarkar madam again.
Yeah.
Few points at least.
Few points at least about
please
our topic.
Unmute. And can we have the CV of Geeta ma'am?
Yeah.
Hi Savita, yeah, please.
Ma'am, it's my pleasure to be with you. And Dr. Geeta Balsarkar is a professor and unit head, ma'am, from SET Medical College, Mumbai. And she's fetal medicine consultant and teacher for MUHS fellowship, editor-in-chief, International Journal in Fertility and Fetal Medicine. And she has edited so many journals and secretary of Mumbai Ops Gynae Society. And she's member of District Quality Assessment Committee for Maternal Mortality in Mumbai and chairperson of Young Talent Promotion Committee of FOXY in 2014-16, conducted PPIUCD program of FOXY in 2016. And she's former president of Association of Medical Women, former president of Mumbai Menopause Society, recipient of the prestigious Hargobind Foundation Award on Medicine in London, and UG and PG teacher, and editor of various books in subjects of OBS and Gynae, authorized various books and chapters in OBS and Gynae. So you have wonderful, ma'am. You all are, and being a part of, it's very, very thankful to being a part of your this with among these pioneers.
Yeah, thank you, Dr. Savita. Can I share my slide, please?
Sure.
So I'm going to speak today about adenomyosis. We all know that March is the month of endometriosis and April is a month of adenomyosis. So here we are around the end of March to speak about both endometriosis and adenomyosis. I'm going to mainly focus on the reproductive and perimenopausal age group because these are the common group of patients that we see in our clinical practice. I'm Dr. Geeta Balsarkar and I'm standing for the post of Vice President of FOXY from West Zone in this election year of 2025. So kindly support me. So to define what is adenomyosis, by definition, it is a common non-malignant condition of the uterus. It is characterized by the presence of endometrial glands and stroma. Not only the glands, the stroma is also there, ectopically placed in the myometrium. What does it do? The adenomyosis induces hyperplasia and hypertrophy of the myometrium, thus causing enlargement of the uterus. So this is the main definition when we talk about the definition. Now, is there any relationship between adenomyosis and endometriosis? Yes, they are different phenotypes of a single disease. Basically, adenomyosis and endometriosis both are different phenotypes of a single disease. This particular diagram explains what happens in adenomyosis. In adenomyosis, endometrium grows into the muscle layer of the uterus, whereas in endometriosis, the functional endometrial-like tissue grows outside the uterus, like bowel. It can go into the ovary. It can go into the pouch of Douglas. It can be anywhere. Now, the adenomyosis causes enlargement of the uterus, whereas in endometriosis, the uterus they can form adhesions outside to the different structures. So they are the different phenotypes of the same disease. Now, if you come to the origin, the human uterus is embryologically composed of the archimetra, which originates from the Mullerian duct, and neometra, arising from the non-Mullerian duct. And adenomyosis and endometriosis both are diseases of the archimetra. The outer myometrial layer of the uterus is composed of highly differentiated smooth muscle cells, whereas the inner myometrial cells are immature. Therefore, if this adenomyosis irritates the inner myometrial cells, they can grow further, causing the hyperplasia of the uterus. In addition to the growth and the hyperplasia, there is inappropriate uterine contractions, which causes retrograde menstruation and chronic inflammation of the pelvic cavity, and thereby influencing the development of pelvic endometriosis. So it is not uncommon to see both endometriosis and adenomyosis in the same patient. The hyperperistalsis results in the physiological and the pathological changes to the endometrial myometrial junctional barrier, which allows invagination of the normal endometrial tissue into the inner myometrial layer. Remember, the inner myometrial layer and the outer myometrial layer are different. The inner myometrial layer are immature, whereas the outer myometrial layer are highly differentiated smooth muscle cells. And then because of this, the inner myometrial layer responds in a different way to the invaginating endometrial cells and the stroma, and this triggers the development of intrinsic adenomyosis. So if you see what are the views on the development of the adenomyosis, current view is that it is a eutopic endometrium. If the eutopic endometrium causes myometrial invasion, then and if this eutopic endometrium goes extrauterine because of the abnormal contractions of the uterus, then you can have endometriosis of various organs, extrapelvic endometriosis, and the other various organs, then which rectum, the uterosigmoid, sigmoid, ureters, bladder, small bowel, cecum, all of them can get affected. But there is also another hypothesis which is going on, which says that what is adenomyosis is intrinsic adenomyosis, and what is endometriosis is actually extrinsic adenomyosis. More research needs to be done to actually call endometriosis as extrinsic adenomyosis, but this is also one of the hypotheses, and there is a possibility. Now, adenomyosis presents several different subtypes. There can be intrinsic adenomyosis, there can be extrinsic adenomyosis, there's something called as adenomyosis externa, and focal adenomyosis. Now, this focal adenomyosis is located in the outer myometrium and not in the inner myometrium, which causes uniform enlargement and hyperplasia of the uterus. Now, if we see the clinical symptoms, the concomitant disease and their frequency, most common presentation of adenomyosis is chronic lower abdominal pain. 77% of the patients present with this. Then there can be hypermenorrhea. Then there can be dysmenorrhea. 30% of the patients are asymptomatic. There can be associated infertility in about 28%. Concomitant diseases that are seen along with adenomyosis are fibroids, endometriosis, and endometrial polyps. All these are hyperestrogenic state. So it is possible that estrogen also affects the adenomyosis. Once it is formed, estrogen may be increasing the problems of adenomyosis. So adenomyosis in 30% of the patient is asymptomatic. Chronic pelvic pain and abnormal uterine bleeding are very common. The diagnosis of adenomyosis has been made by pathology after hysterectomy. When we were resident doctors, we were often told that if it is diagnosis of adenomyosis, it will be you'll come to know after hysterectomy, mostly by the microscopic criteria. However, preoperative diagnosis by MRI is becoming more common, and a variety of medical and surgical treatments are now being recommended. The diagnosis of adenomyosis is used to be used as an indication for hysterectomy. If we see the ultrasound features of diffuse and focal adenomyosis, the ultrasound feature is the serosal contour of the uterus is enlarged in diffuse adenomyosis, and in focal adenomyosis it will be irregular. In the lesion will be indistinct in diffuse adenomyosis, whereas in focal adenomyosis you can see well-defined cases of cystic or hyperechogenic lesions surrounded by normal myometrium. So there is a difference in the shape, the contour, the shadowing, the echogenicity. So the main thing of is differentiating between a diffuse and a focal adenomyosis, because the treatment and the presentation in these cases is very, very different. Adenomyosis is often associated in the presence of fibroids. It is common with endometriosis. It is associated with abnormal uterine bleeding, and symptoms are chronic pain are more likely in uteri with fibroids if adenomyosis is present. They say the pain that happens because of fibroids is mostly because of the adenomyosis that is present in addition to the fibroids. So adenomyosis affects the reproductive outcome. Now, how does it affect? It affects the sperm transport, it affects the receptivity implantation and causes recurrent miscarriage, it affects embryo transfer, and it affects ovum transfer. At an anatomical level, it causes enlarged uterus, distorted anatomy, and an intramural adenomyoma, which causes distortion of uterine cavity and abnormal uterotubal transport. At a cellular level, It can cause cellular and nuclear hypertrophy, abnormal shape of nuclei and mitochondria, and the abundant myelin bodies, which cause dysfunctional uterine hyperperistalsis. It causes increased thickness in the junctional zone, which causes the hyperplastic myometrial tissue, increased intrauterine pressure, and dysfunctional uterine hyperperistalsis. All of these affect the reproductive outcome. Nowadays, we are seeing adenomyosis in the young population as well, and in the early reproductive age as well. So what are the treatment options that are present, including pre-treatment of adenomyosis in infertility? If we have infertility patients who have adenomyosis, we need to pre-treat them to make them receptive for the embryo. So we can give NSAIDs, combined oral contraceptive pills, mostly long cycles, 90-day cycles are given. You can give progesterones. Levonorgestrel IUS is very good intrauterine system. GnRH analogs for short term, you can give leuprolin, tritolin, buserelin, etc. And the newer approaches like selective progesterone receptor modulators, GnRH antagonist, valproic acid, modulation of prolactin and oxytocin receptors, and antiplatelet therapy. Coming to surgical, Dr. Subhash Malaya is going to talk about most of it, but a complete resection of adenomyoma or localized adenomyosis is possible laparoscopically, and cytoreductive surgery of diffuse adenomyosis, the laparoscopy is better and then laparotomy, and hysteroscopic resection can also be done. The other methods which have been tried are high intensity focused ultrasound, hysteroscopic endometrial ablation, and the uterine artery ablation. These are the other methods that have been tried. Now, surgical techniques, depending on what is the extent of the excision, the route of the surgery, on the techniques, we can classify them as type 1 and type 2, where type 1 is a focal or localized endometriosis. The incision has to be complete. It can be done laparoscopic or via laparotomy. The classical technique, that is adenomyomectomy, the U-shaped technique, overlapping flaps, and the triple flap method. These are the types for the localized adenomyosis. Whereas for diffuse adenomyosis, you have a cytoreductive surgery, which can be done laparoscopically or via laparotomy, classical incision, transverse H-shaped incision, wedge resection of the uterus, and an asymmetric dissection of the uterus is done. Now, is the ovary the intermediate point between the endometrium and the myometrium? Are we missing something? Now, if you see this particular side, you will know that the ovary is the intermediate point, and if there is adenomyosis in the uterus, it will be often associated with endometrial hyperplasia. Adenomyosis is often associated with endometrial carcinoma, and adenomyosis is often associated with endometrial hypertrophy. So we need to think, is the ovary the intermediate point between the endometrium and the myometrium, and which corrupting hormones? Is that the reason why we are seeing more adenomyosis nowadays? Now, coming to this particular case, 28-year-old woman with irregular heavy menstrual period, cyclic pain, dysmenorrhea, deep dyspareunia, and vaginal examination, enlarged, soft, antiverted, extremely sore, side-to-side mobility uterus, no palpable adnexal mass. Ultrasound was suggestive of adenomyosis. MRI was done to confirm the diagnosis of adenomyosis. Now, if this patient is desirous of pregnancy, we have to do the infertility workup, the hysteroscopy, and if there are no other evidence of infertility, we have to discuss treatment option with the patient. Either she goes for laparoscopy, and if there are any negative findings, then she goes directly for IVF. If there are any endometriosis or any other adhesions that are associated, then she needs to be treated for that. If the patient does not desire the pregnancy, then medical management is good for adenomyosis. We can insert an LNG IUD. Sometimes, if they're very bulky uterus and patient is very obese, then we may need to insert even 2 LNG IUS at the same time to have the same effect. Then we can supplement it with oral progesterones, danazole, or GnRH agonists. So if we see this, this is how a normal uterus looks, and this is how an adenomyotic uterus looks. And this is how an adenomatic uterus looks. So if it is a steroid hormone, then we can use combined oral contraceptives, aromatase inhibitors, GnRH agonists. And if there is inflammation, we can use NSAIDs and natural supplements. Peptide hormones like bromergocryptine, metformin are also used for treatment. And lincitinib is a growth factor which has been tried in adenomyosis, and some other natural supplements has been given. So these are all the various modalities that has been used in adenomyosis. If you don't know the exact reason and there is no one form of treatment, then you have used various treatments, and each one has a particular effect. Like if we are using for inflammation, we use NSAIDs. We can use metformin, we have bromergocryptine, lincitinib. Then we can give natural supplements, GnRH agonist with the add-back regime, and which affects the estrogen metabolism, and the anti-aromatase. So these are all the treatments that are used in medical management of adenomyosis. What about perimenopause? Adenomyosis may be evaluated in menopause by transvaginal ultrasound or MRI. Adenomyosis expresses markers of epithelial mesenchymal transition, inflammation, and fibrosis also in postmenopausal women. Fibrosis is one of the key features of adenomyosis after menopause. So this is the ultrasound picture of adenomyosis and how it is seen on an MRI. This is an MRI. We do not routinely do MRI for adenomyosis, but if we are not able to come to a diagnosis, then we can use MRI. In our country, MRI is very costly, so we have to, sort of treat the patients many times on ultrasound. Now, sorry about this particular slide. This slide tells us how we can use a various medical armamentarium that is there with us, the GnRH agonist, the combined oral contraceptives, the NSAIDs, the progestins, the aromatase inhibitors, and the GnRH antagonist. And what is their various action? Sometimes we have to use more than one. We may have to combine one with the other when we are managing patients for adenomyosis. So if it is NSAIDs, then we have to remember 18% of patients do not respond to NSAID. So long-term use of NSAID may result in peptic ulcer, liver and kidney injury. If it is combined oral contraceptive, it reduces menstruation, relieves dysmenorrhea, fit for contraception. But remember, it increases the risk of thrombosis and embolism. We have to use with caution in patients who are 40 years. If it is androgen derivatives, recurrence happens after drug withdrawal. Androgen-like adverse reactions. Synthetic progesterones, adverse reaction include irregular bleeding, breast discomfort, headache. If it is another traditional Chinese medicine, there are some reports, they provide completely individualized treatments, and some of them, can be used for management of adenomyosis. If it is GnRH agonist, then we have to remember it is like leuprolin acetate. They inhibit the HPO axis, reduce ovarian synthetic steroids, uterine volume is reduced and pain is relieved. Whereas long-term treatment will lead to perimenopausal-like symptoms, and there is recurrence after withdrawal. Usually it is used as a pre-treatment in IVF. LNG-IUS, very, very good. Acts on the endometrium directly, antagonize the endometrial proliferation, few side effects, but it's possible to fall off or move down because there is a lot of space in the enlarged uterine cavity, minor bleeding off and on, and amenorrhea. And then HIFU and other conservative surgeries have also been tried in the adenomyosis. So, coming to what Dr. Ramani said, that could adenomyosis be the result of the abnormal gut microbiota? Yes, there are some studies which say that the gut microbiota are responsible for the endometrial, the organisms which are present, the vagina as well as the gut. So there is definitely a relation between adenomyosis and the gut microbiota, which has been proved, but exactly which one, a lot of studies are going on. So we need to know that the gut microbiomes could also be responsible for adenomyosis and endometriosis. So this is an adenomyosis and endometriosis awareness month. We have to remember that any patient who comes to us with painful or heavy periods, increased risk of infertility, painful intercourse, elevated estrogen signs, fatigue, depression, bloating, anxiety, please remember it could be adenomyosis as well. Thank you for a very patient hearing. Thank you.
Dr. Savita.
Yes, ma'am. It was wonderful talk, ma'am. Am I audible, ma'am?
Yes, Savita, you are audible.
Yeah, ma'am. What's about the new drug Sun Pharma has been launched, Ergolix? You have
Yeah, but that we are primarily now we are using for endometriosis pain relief, not so much for adenomyosis, but we could try.
Yeah, it was wonderful talk, ma'am. You have explained everything very well, ma'am. It's very usable in our day-to-day practice. Thank you, ma'am, for being with you, ma'am.
Yeah, thank you. And I'm standing for the post of Vice President from West Zone. Please support me.
Yeah, sure, ma'am. Sure. All the best, ma'am.
Thank you.
Continuing with
If
the
you want to have a special message, you can talk expert as an expert. Dr. Raki, welcome.
Thank you, Jairani. But Elagolix, Madam Savita was asking, Elagolix does helps in this adenomyosis also. It is basically a pain relief. So it does help for both, Dr. Geeta, for both the aspects, because that is a very good new kid in the block, which would help for all of us to write down for the patients, and that would help them out with the pain management for most of the patients in the tablet form.
Correct.
And,
Correct. But as of now,
I
they're
have
promoting it for endometriosis.
Yeah,
the
Geeta, I have been
adenomyosis is also part of the endometriosis only. Because of endometriosis only, the adenomyosis is happening. And if the patient is having pain more with the adenomyosis, in that aspect, it would help. But not for the other aspect that it should decrease the bulk of the uterus, or because we cannot promote and give elagolix for a very long time. It is just a stopgap treatment only for 3 to 6 months, though it has been given. Trials are there, phase 3 trials are there for good 4 years, 5 years, 4 years plus. But still, the bone density and the other things follow through. We have to give them.
And cost is also a factor.
Cost,
Yeah,
definitely. If the
Raki,
patient has got, that has to be outweighed, na. If the patient has got lot of pain, then definitely they would opt for that. If they don't want to opt for the hysterectomy or anything.
Surgical management.
Yeah, Raki, Asha Rao here. And pain relief was pretty good with the Elagolix. And I have tried it on 5 patients of adenomyosis because it's only 2 months since we're having it. Even the volume reduction seems to be rapid. I'm waiting for some more time. Because these infertile women require only a short gap treatment. They do not require a long-term treatment. So you can collect the eggs, make embryos, freeze them, and then wait for 3 to 5 months, reduce the volume, and then do a transfer.
Those small, Dr. Asha, those small islets of hemorrhagic fluid which is there in the myometrium, that also is very beautifully disappear with that.
Yeah, give me another 2 months, I'll tell you more about it.
Yes, we'll wait for that.
But just now, I'm pretty happy even for adenomyosis.
Yeah. Same here.
Ma'am, in fertility patients, you are dealing with this laparoscopically removal of adenomyomas. How you are getting them results?
I think, Madam, Dr. Subhash will enlighten you about all these things in his talk.
We'll wait for the next talk. Subhash is an expert over here.
Nice to meet the experts, Dr. Asha Rao ma'am, Dr. Raki Singh, and Dr. Subhash Malia. Thank you. It's our privilege to have you. And continuing with the next academic. Thank you. Same to you.
Hi, Aruna. Lovely seeing you.
Thank you, ma'am. Love you too, ma'am. So actually continuing with the next session, can I invite the chairpersons, please? Yes, Dr. Kamla Verma, Professor, OPG, GMC, Parma. She's MBBS, MS, FICOG, member of FOXY, member of Menopausal Society, Bikaner branch. Area of interest is infertility and operative gynecology. Various publications in national and international journals. I welcome you, Dr. Kamla Verma. Are you there? Okay. May I take the privilege of introducing dear friend, Dabbula Babu, Dr. K. Subhash Malia. I call him that because he does a lot of laparoscopic surgeries and he's an expert coming to Telangana and Andhra also. He's endoscopy Germany, PVS Hospital and Baby Memorial Hospital, Calicut, Kerala. Chairperson, Foxy Endoscopy Committee 2124. Member, Specialist Board, International Board of Examination, Minimally Invasive Gynecology 23 to 28. Secretary, Kerala Federation Obstetric Society 24 to 27. Chairperson, Medical Legal Committee,
Thank you, madam.
KF4G 2122.
Thank you very much, madam. Thank you very much. And
He's an excellent surgeon. And Dr. Subhash, I welcome you.
thank you,
Please
ma'am.
give
Thank you
your
very much.
Thank you.
Thank you very much.
Subhash, hi.
Hi, namaste, madam. At the outset, let me thank the whole galaxy of senior members of the fraternity, of the Federation of Foxy, also TNFOG and MOGS also here. And of course, I can see the president, the immediate past president of Bangalore Society, Dr. Rekha madam also here. And would like to also thank Dr. Savita madam, Dr. Rakhi madam also is also here. And the Gen Next Ashwin and team is also here. Anyway, at the outset, thank you, Ramani madam and team. And of course, Jeremy for the wonderful opportunity. I will go straight away to the topic. And the topic that has been given to me today is fertility enhancing endoscopic surgeries. I'll try to keep it very simple and more of practical aspect. And it would be wrong if it not be wrong if I say that when we have people like Asha Rao madam, Ramani madam, and all the galaxy of seniors here talking about this topic of fertility enhancing endoscopic surgery is slightly dangerous because you're a bit scared about it because there are a lot of seniors over here. So correct me whenever I go wrong. If at all I go wrong, please do help me out, ma'am. These are my credentials and everything. The topic again is rational application of endoscopy in infertility management is the topic today. And please understand that the problem that we have with endoscopic surgeons and ART specialists is now the ART specialists always feel that the endoscopic surgeons are very rude, very harsh. They destroy the endometrium, they destroy the eggs, they destroy the environment, and causing a lot of problems. But let's understand that we are here for a common goal, and the common goal over here is actually your fertility aspect. That is for the lady to become pregnant. So it's like the middle path. Na, बीच में ना इधर का ना उधर का. So that is what the whole idea is. That let's work towards forming and having a goal of achieving pregnancy and more importantly, healthy baby. Of course, we'll also review certain guidelines pertaining to fertility enhancing endoscopic surgeries, and of course to share some tips and tricks in laparoscopy. Now, surgical procedures that enhance fertility is not basically, let's understand, it's not only for the IVF. We are not here for the ART specialists alone. Rather, we are here to spontaneously enhance the spontaneous pregnancy. So, idea is, almost 60 to 65% of these patients will have spontaneous pregnancies. It is not that I'm against ART specialists or I'm saying they don't do for ART, but actually for the normal pregnancy. Of course, you do help out your friends and enhance the IVF outcomes. Our job here becomes very simple that the ART specialist would like us to do some procedures which would help them out, and our idea is to enhance. And third part is, you should do something called as a fertility preserving surgery versus a fertility enhancing surgery. There are two different aspects. Where you do the fertility preserving surgery is where you don't be very radical on these structures and try to preserve as much as possible. And of course, the other one is fertility enhancing procedures. Great explorers have always charted the unknown territories and changed the world that we live in. A lot of experience. The same way, we surgeons are explorers and always been, that's why it's called as exploratory surgery. We always try to find out something wrong or something good. But of course, it is very important, pertinent for us as a surgeon to know when to stop and convert. Merely having a scalpel in the hand doesn't mean that you go on operating and do anything that comes in front of you just has like a hammer and a nail. No, we are here to know when to stop and convert. That is very important. When to stop and surgery. Of course, we always say that surgical is always a team, and the team here means together everyone achieves more. So the ART specialist, the anesthetist, the endoscopic surgeons, the embryologist, all of us, the obstetricians, everyone together, we actually go towards and forming a pregnancy over here. So let's start from the morphological causes. We'll start from down from vagina and we'll enter into the peritoneal cavity. So we'll go from down south. Now, please understand that whether a surgery, the question here is whether to do an hysteroscopy prior to IVF. Now, routinely, many centers do not prefer doing it because, as they have rightly said, there's no point in doing an IVF, hysteroscopy for every case just prior to IVF. What has been said is, when you find out, there's only 10% of these patients do find out some positive finding. Just to find some 10%, you don't have to do a necessary procedure or a morbid procedure for about the 90% of these other patients. Hence, once you've had a prior failed IVF, once you have had a failed IVF and then you do a hysteroscopy for these cases, you find almost about 40% of these patients, will have some positive finding. So I personally believe that, once you've had a problem, then of course you can go ahead and actually do a hysteroscopy for such cases. But please understand that nowadays, all our ART specialists, all the senior members do have very good ultrasound. They're very good sonologists. Of course, I'm an endoscopic surgeon. Probably I'm not a good, uh, what do you call that? Sonologist. But actually, all of us, all the other seniors are doing very good. So I believe that the surgical aspect can also be reduced with a good 3D ultrasound also. Of course, these are found out in these cases. And of course, increased pregnancy rate and recurrent implantation failure has been seen in such cases. Okay. So again, scratching was something which did come out a big way, but it didn't actually come out. Later on, it was not very helpful for that. Of course, efficacy of hysteroscopy, you can always see that all the pregnancies are about the odds ratio is about 1.45. So doing a hysteroscopy after failed life actually really helps you out in having a better qualities. Okay, this is something which has been seen again. Now, for every case, we do an hysterolaparoscopy. Sorry, I'm not here to say that, no, don't do that. I'm not here to say that, no, whatever comes down your way, if you have one failure after some 6 months, do a laparoscopy. No, I'm not here to say that. It is said that the patients who had unexplained infertility, they've been treated very well, they've been treated very, very vigorously, and still they do not have any positive finding or anything. In such cases, there is a role for doing hysterolaparoscopy. As you can see over here, almost 33% of the patients had something like about an endometriosis, which was not diagnosed, and about 25% of these patients had a tubal disease or a pelvic adhesions. Of course, you can see that it is worth doing it. And of course, I can see the Indian surgeries also have said that the similar ones actually. Now, hysteroscopy in infertility, you would be able to pick out something like a hydrosalpinx, endometriosis, you can have a myomectomy, adenomyosis and everything. Okay. Now, vaginoscopic technique is what we normally do in hysteroscopy. Gone are the days when we hold the cervix with an Alice and then we go inside. Now, what we do is we do not start directly in the cavity, but rather what we do is we actually go down and find out in the vagina. The reason for that is, when you do such case, as I can show you, there could be a lot of cases like cervical cause, like scarring, inflammation, infection, narrowing, obstruction. Now, you can say that, of course, the menstrual blood is coming out. So what is the point of doing this? But please understand, yes, when you have something like this over here, you can see over here, there's a lot of addition over here. You don't expect this lady to be pregnant very soon. Of course, by doing this, you can see over here, very simple adhesive lysis. All the synechiae can just be removed out and it would definitely help you out. You can see the dirty blood actually coming out. When you have such dirt over here inside the cavity, do you think that the pregnancy is going to be there over there? Definitely not. She's definitely going in for an abortion previously also. So basically, when you open it up, you open the cavity, the environment inside the cavity looks good by a simple thing. Again, sometimes you may have a Nebotian cyst, you can have a cyst. Suppose when you do an IVF, you go and touch the Nebotian cyst, you go and touch the cyst. Of course, there will be some prostaglandins which are released, and that would actually cause your failure of your cycle also. So these are very important that you do a hysteroscopy, which is actually you start from the vagina. You can see some puckering in the posterior fornix. You may see some endometrios on the posterior fornix. That would give you an idea that probably this lady would have some other finding also, which would have been missed if you do directly a hysteroscope where you're holding the cervix and not the vaginoscopic technique. Again, over here, and the case okay, you can see over here. Now, the tips and tricks over is you don't have to cut it. You can just see it, go inside and open up. Go inside, you just open up. Go inside, you just open up. There'll be small fibers. These fibers are small over here. And you can just go and do this, and that would actually help you out in entering the cavity. You can see over here. I'm not doing anything, just simple dilatation. Yes, these are thick fibers. These are Asherman's grade 1. Of course, Asherman's 2 and 3, as the seniors would actually say, there wouldn't be much of a role in Asherman 2 and 3, yes. But the simple ones, the simple ones, they would definitely be helpful. You got a good cavity. You can see here, it's a good cavity over here. Because the smaller septum also would be here. And that would be helpful for the same. That could be congenital and benign causes, of course. You can see over here. Now, in this case, you can see over here. Okay, as you can see on this case over here, this is actually a unicorn, but actually the cavity space was very small. So we're doing a hysteroscopic matroplasty over here with a monopolar. Of course, you have the bipolar tweezer also now coming up. Okay, you can do this. Now you can always argue that this is not a good procedure, this is not a bad. Of course, we can always go to the pros and cons of every procedure. But my understanding is this was a very small cavity. You do a lateral matroplasty, the space becomes big. Of course, what was destined to be about 6 or 7 months of pregnancy, it can go up to 8.5 months. And that would actually be very good for the take-home baby rate would be better for these cases. Okay. Of course, congenital for bicornate uterus, you can have unicornate, Adelphia, septate, and arcuate. With the bicornate and unicornate, not much can be done. These are all congenital. And for diadelphys, unification procedures and all those do not help much. So let's be very honest about it. Just because you have a bicon, you just don't do a unification unless and until you get repeated failures and you have no option, because you can go for a Straussman's metroplasty also. Septal resections. Now, indications are very, very important. When you have a recurrent pregnancy loss, a long-standing fertility prior to ART, of course, the question which I've asked is incidental finding on diagnostic hysteroscopy. If you have a very small subseptum, please understand less than 0.5 centimeters, you don't have to do anything. It is actually a very normal finding. We do feel that probably we would like to cut it across, but that's not required for this. In arched uterus, it's not much of use. So septal resections is very, very simple indications that if had recurrent pregnancy losses, long-standing fertility, yes, you would like to do this. Otherwise, not for every case. Just because you find a septum, you just don't cut it, of course. Submucous fibroids and polyps, whatever is inside the cavity, it is a bad thing. No, you'll have to remove it across because they always release prostaglandins and COX-2, and they wouldn't be good. Now, what has been said is when you remove the polypoidal lesions, it has significantly improved the pregnancy rate in IUI. Okay. Now, again, I would just skip this for positive. Now, again, Cochrane review also says that when you have a subfertility patient, you can see the odds ratio onto the right, which actually favors polypectomy. Again, if you have a very small polyp, less than 0.5 centimeters, just wait for 2 months. Actually, they would actually be, just go off. Give them some 2 cycles of OCPs, probably they would go off. But if it's a bigger polyp, they wouldn't go off. Okay. Now, again, similar ones here, polypectomy, the similar ones again. You can see this. For submucous fibroid, I think there is no other doubt. You can definitely go ahead and remove. If it's a very small submucous fibroid, it's a grade type 2, yes, you can use a generic analog, definitely helpful. Or else basically what we do is we actually do for a resection over here. Just for the sake of, saying this is how you do with a monocular loop. You actually go down. It's a very easy one. It's a very easy procedure. But of course, the surgery is very, very easy. But the problem is when you remove it out. It is so very difficult. It is so very cumbersome. You should know the pros and cons of using a monopolar and a bipolar. Be very, very careful about the fluid overload. You have to be very, very careful about these things. I wouldn't go to that. It's a different topic altogether. But yes, removal of submucous fibroid would definitely be helpful. Again, polypoid lesions over here. You can see over there's multiple polyps here. And of course, a fibroid also here. You can see the bipolar loop being used over here. The advantage of using a bipolar is your margin actually increases slightly more in terms of your fluid overload. But please understand a lot of air bubbles which you can see here. And the problem with the bipolar is you have a lot of air bubbles which keeps on coming over here. Okay. Again, all these are very good procedures. You can see the odds ratio. They would definitely be favoring myomectomy and they would actually help you out. In terms of endometritis, synechiae, thin endometrium, it would be helpful. Now, intrauterine adhesions can always cause recurrent pregnancy loss. And of course, you just don't need a hysteroscopy and also diagnosed with a sonohysterography and HSC also. Of course, the Indian studies also have come out that it's not very, very procedures. Now, proximal tubal occlusion is very, very, very important. Oh, I'm sorry for this. This is tough. But what I would like to show is in a case of proximal tubal occlusion, yes, doing a cannulation would definitely be helpful. But if you have a mid-tubal block, it is not much helpful. Just because there's a tubal block and you know how to do a cannulation doesn't mean that you do a cannulation for every case. Now over here, this video is not playing. I'm sorry for that, but please understand the stent is gone inside the cavity. This is the wrong method of doing. You actually put in the stent later on. You just go do stent because if you go with a stent, J-shaped stent, that would actually cause perforation again. Hydrosalpinx, I think it's a mild one. You may take a risk, but of course, when you have a bilateral hydrosalpinx visualized on TVS, I think definitely that should be treated. Okay, you can do a removal, good, but sometimes the surgeries are so badly done, the additions are so bad that you would not be able to do anything. As a last resort, you would like to aspirate or disconnect it. Disconnection is always good. Now the theories I wouldn't go into because of lack of time. It is gamete toxic, it is embryo toxic, receptivity is also altered, the blood flow also is increased, and hence it is not a good thing to have an hydrosalpinx. If you have an obvious hydrosalpinx, please do remove it. Again, you would do that. You can you can cut it with the bipolar, anything is fine. But please understand, sometimes what you feel like an hydrosalpinx is basically due to the adhesions. And here you can see how these are not basically hydrosalpinx. You can do a simple adhesiolysis over here, and do a simple adhesiolysis over here, and that would actually see here. You do an adhesiolysis, you take it from the ovarian fossa, and that would actually really help you out. Can you see this? It would really help you out. So you wouldn't need to remove a tube in such cases. A good anatomical dissection, a good anatomical clearance would actually definitely be helpful. I'm not saying for you can take a risk with hydrosalpinx, but some hydrosalpinx are anatomical blockage. You can just clear it off and they would actually be helpful. Now, the question that is asked is, I do a salpingectomy, I go very close to the ovary, I destroy the ovary, I decrease the blood flow, all these things are said. But please understand, we have very good studies, that in a short term and long term, both which have said that salpingectomy does not compromise the ovarian reserve in short term or in long term, of course. This is just for the sake of, there's something called as occlusion, hysteroscopic tubal occlusion. It costs about 1 lakh rupees. Not interested. I'm just saying for the completion's sake, you can do this. Peritubal adhesions are very, very important. Please understand there will be some patients with very flimsy peritubal adhesions. Okay. And those, when you just remove the normal tubal anatomy and the motility is back, and that would actually help you out with increasing your pregnancy rate. I'm not saying that you do an hysterolaparoscopy to find out a peritubal adhesion, but of course, when you see that, please do remove it. It would really be helpful. Now, the king of the day, endometriosis, I will not go into the depth of it, but of course, LAP is a good treatment. You can do infulguration. What I would like to say is, by the moment you see an endometrioma or an endometriosis, please don't leave it as a diagnostic. Please remove it. It is very, very important. Now, for the problem of a surgeon, as I keep saying, is every time when we get a case to operate, we never get a virgin case. We always get a case which is between the oral with a tablet for about so many months. It is so very difficult to get a good plane in such cases, and hence in such cases, use of vasopressin is a very good one. Okay, use of vasopressin is a very good one. You can see this kissing ovaries and everything, but please understand, use of vasopressin help you out. And the other controversial question is whether you put the vasopressin on the ovary or on the posterior surface of uterus. I would personally prefer you to put on the posterior surface of the uterus, because what happens is when you do the adhesive lysis, more of the bleeding is going to come from the posterior surface, which will actually hamper your field and not on the ovary. So hence, it is always a good option to put on the posterior surface of the ovary and take out a good cleavage. Very rarely, when you have this previously medically treated patients, you don't get a good one. You don't get a good cleavage. The idea is, it's called as the inverted umbrella technique, where you just give a cut, a deliberate cut, and then you open up and do a cystectomy. Of course, I wouldn't say that medical and surgical treatment is the first option, the last option definitely. But surgical patient, when you do it, almost 50% of the poor women would definitely conceive spontaneously, and that would be done. But again, the problem that arises is, it is always a controversial one that, everybody would blame the endoscopic surgeon. You have destroyed this, you have destroyed that. But please understand that, even in the quality of oocytes that you get, the quality of oocytes that you get in endometriosis patients is actually very bad. You can see with a lot of studies which have said the same thing, a lot of big names. These are all big names. Okay. Even when you operate from a normal operated patient also, it's very good, bad. Again, when you do this, you see the oocyte retrieve. The quality of oocyte is also very bad. The endometrial receptor is also equally bad. So I would say that be a little bit gentle on your endoscopic surgeon. Don't blame them too much, because per se it is very, very bad per se. Now, in stage 3 and 4 endometriosis, if your hands may be itching as a surgeon to operate, but please understand that in stage 3 and 4, if they're not conceived 1 year after your surgery, I believe send it to your ART specialist, send it to your friends. Even if you don't like them as an endoscopy, you would be getting less money out of that. But no, but it is better for the patient to always send it across to an ART specialist. They would do justice to the patient. That is very, very important. It's not because, again, as I keep saying, just because I have a scalpel in it doesn't mean that I operate. There would be a better one. There are very few indications of surgery when you have pain abdomen, yes. When you have severe pain, when it's rapidly growing, then probably you may be having a justice in operating a reoperation or a secondary surgery. But otherwise, the ART specialist, your friends would do a better job for those patients. Fibroids, very little about it, nothing much. Now, this is a wrong slide if I'm not wrong. What happened? Yes. Submucous fibroid, I believe we have no other option. We have totally agreement that submucous fibroid of any size, you would remove it for this. Subserosal fibroid, we would not advocate removal unless until they are about 7 or 8 centimeters, really troubling the pain aspect, then you may operate, or else no. Intramural fibroids, which are impinging the cavity, I believe there is no doubt among all the seniors and all the juniors over, if you have something which is impinging the cavity, yes, you would definitely like to remove. This video which I am showing you is, the question that arises is, I have gone inside the cavity. Should I suture it separately? Should I take a Vicryl 2O, or should I go in mass closure? Please understand. There is nothing to be worried about, operating that, you'll have to take it in 2 layers or 3 layers, endometrium separate layers. No. Your idea is very simple. Just approximation of the tube. You can take a baseball suture, you can take 2 layers, no problem. But please understand that your idea of approximation is just an approximation of the fibroid tissue, not strangulation of the tissues. The more closer and the more harder that you close, the blood flow is going to be hampered, and that would actually give you a very wrong impression in terms of your future, fertility. Because what happens is the more closer, the more tighter that you close, the blood vessels are going to be very, very strangulated, and the healing is going to be bad, and rupture can occur. With all humility and all respect, I would suggest that all my life I've done so many thousands of cases in myomectomies, and none of my uterus have ruptured. Probably I was lucky enough. I would pray to God. I'm always grateful to God. But the reason is you follow certain principles that I always would like to take care of, the vessels, not a use of. Now, the dilemma is over here in myoma is very simple. This is the last couple of minutes of my talk. I would finish off in 2 minutes. Is intramural myoma not distorting the cavity? Now, whether if I remove those, it will be helpful. All the studies have said that, whenever a previously failed IVF and have lost said fibroids which are less than 5 centimeters, you do not remove. But when you had a all these, any fibroid for the matter, when you have multiple fibroids less than 5 centimeters, in any patient, they always had a lower implantation rate, they always had a lower pregnancy rate, and they always had a lower delivery rate. Please understand, I'm not asking you to operate on these patients. I'm saying they always have a lower implantation, pregnancy, and delivery rate. Now you can see here, ones which are less than 4 centimeters, not encroachment cavity, I would also suggest to all of you that please do not operate such cases. That is not required for such cases. But if it is more than 4 centimeters and the patient has already been subject to treatment and they've had a previously failed IVF, I would definitely request you to think in terms of surgical removal of those fibroids. But please understand, as the age increases, your removal will be better. The presence of intramural cavity, non-cavity distorting intramural fibroids reduces the pregnancy rate by about 21% compared to those patients with no fibroids. So hence, those patients who have had a previously failed IVF has a fibroid which is more than 4 centimeters, not encroaching upon the cavity, my humble suggestion would be that please think in terms of surgical removal, because that would definitely be helpful for those patients. Adenomyosis has already been taken in detail by Madam. Localized excision, yes. But if it's a globular one, there is no point in doing a surgery for such cases. As Dr. Ramani Devi Madam and Dr. Asha Rao Madam will actually impress upon, along with Dr. Geeta Madam who have told, use of LNG, GNR channel log, followed by your LNG IUS would definitely be helpful. Okay. Of course, if you give a GNR channel log, definitely give 2 to 3 months of separation, and FET can always be helpful about here. But this is a very simple, very nice video over here, that when you think in terms of endometrioma, in terms of adenomyosis, suddenly you go inside, you give a vasopressin, everything looks very nice, very good, very nicely done. You're expecting that the adenoma is going to come out. See what happens. I'm putting my myoma screw also, giving a very good cut. And the sound which comes when you cut, katak, katak, katak in endometriosis, in adenomyosis is very bad. I always would feel that you should charge 4,000 or 5,000 rupees extra for a scissor, extra for every case of adenomyosis, because every case, a couple of cases of adenomyosis you do, your scissors goes out of hand, right? And this is what happened. Basically, it was not adenomyosis, it was actually an adenomyotic cyst also. Please think this is not acum. This is not acum. This is not acum. Okay, there's an adenomyotic cyst also, which can also be seen very rarely. Just to break the monotony, I just thought it. So fertility sparing or treatment options of adenomyosis is, of course, general channel log is a good one. Osada's technique, open technique looks very nice, but somehow I'm not very, very confident about saying that. Last slide. Specific for ART, for lap ovum pickup, very rarely, when you really are not an option, you can think of that. Transplant again as a last resort. Whenever ovarian torsion, very, very important, try to preserve the tube and ovary for a long term. It's very good. For an ectopic, of course, yes. Ovarian tissue removal for cryopreservation also done. Of course, stem cells are coming in a big way. You can always use endoscopy for a stem cell also, though it is the last option for it. Ovarian transposition in terms of, in terms of radiotherapy also. Of course, in terms of borderline tumor, also think in terms of doing endoscopy and not merely going and operating big laparotomy incision, removing the ovary. No, you can always give that lady in terms of borderline, you can always give it. Ladies and gentlemen, I always would say that, whenever you teach somebody, you learn so many things. That's my dictum, which I've always learned in life, that we think we know many things, but when you teach, you learn many things, because there are a lot of people who would actually be telling you different. Sorry for this slide, but as I always say, always aim high in life. That always is something which I always do in life. Always aim higher in life is something which I always say. Now, my humble request to all of you, please forgive me if it is I'm not standing for election, but I would request all of you to please support Our president, Dr. Kunju Moideen, who is the president of the Kerala Federation, is standing for the post of Clinical Research Committee of FOXY for the year 26. The elections will be held in 6 months' time. So humble request to each and every one of you, please do support my president, Dr. Kunju Moideen, for the post of Clinical Research Committee. Thank you. And I'm open to questions, if any, or we can straight away go to Dr. I can see Ashwin is waiting eagerly to start his panel.
Thank you for that excellent talk, Subhash, and thank you for giving us all the tips and tricks of different endoscopic techniques. That was really nice. Thank you so much.
Again, I would like to wish the very best to all the candidates who are standing for the vice president post, the committee post of FOXY, and I humbly request each one of you to somehow cross the finishing line this time, all of you. So please, it's all about, keep my fingers crossed and my humble wishes and the
Thank
best
you.
wishes. Thank you very much,
Dr.
ma'am.
Thank you.
Jairani.
Yeah.
Ma'am,
Thank you,
thank you, Jairani madam.
Subhash. Thank you.
Thank you, Jairani
Thank
madam,
you so
for
nice for
the
giving a very comprehensive and very nice presentation. And it is really nice. All your videos, as usual, like you, it is so much nice and clear and clean. Thank you. Thank you for sharing all your knowledge and all your expert.
Thank
Madam
you.
Asha, madam, you want to
Always so smooth and so easy to understand, and he makes the whole subject look so easy that it is
it is
algorithmic
only
approach 1, 2, 3, 4, and then you do this, then you do this, and then you follow this way.
मैंने
And
अभी
really
मैंने
from
अभी सीखा है, मैंने अभी सीखा है कि आराम से भी बात कर सकते हैं, नहीं तो हमेशा मैं इतना स्पीडली बात करता ना, तो इस बार भी मैंने सीखा है अभी.
now you were superb today.
Yeah,
Thank you,
Subhash,
Dr.
lovely talk.
Subhash. Thanks
Subhash,
for
lovely talk. We
Subhash.
learned all about hysteroscopy and laparoscopy.
Thank you, ma'am. Thank you, ma'am.
And
देश
you
की
didn't
तरफ
take,
नमस्ते, देश की तरफ.
you didn't give me the tips of how you will remove a big subendometrial fibroid. That's the real tough point. And you didn't say how to remove it.
Any case, any submucous fibroid which is more than 3.5 centimeters, if you're a very good endoscopic surgeon, if you're a very good hysteroscopic surgeon, you may attempt it at hysteroscopically. But I, for one, the moment it's about more than about 4 centimeters, I would say no heroics. I would play it very safe. I'll go laparoscopically. I'll remove. In advantage, I would do much less damage to the endometrium than I would do from below. Okay, and I would say no place for heroics. There is no place for heroics. Your fluid overload, death on the table, you will never be justified. No, of course, not everybody can be Osama Shoki. Not everybody can be a Milind Telang or a Damodar Rao. Each one of us have our own limitations. So I believe always safety first. Safety first is what I would suggest. देश दीपक जी, नमस्ते.
हाँ नमस्ते.
कैसे हैं सर?
बस बढ़िया. तुमने तो कहते हैं गागर में सागर भर दिया, ऐसा पूरा एक ही कम समय में इतनी सारी चीजें हैं.
नहीं सर, जयरानी मैडम डांटे की टाइम हो गया है सर. चल थैंक यू सर.
कम समय में सब चीजें कवर करना वेरी डिफिकल्ट फॉर enhancing endoscopy surgery.
Thank you, Dr. Subhash.
Thank you, Subhash, and thank you, Geeta madam, for their wonderful talk, and a very special thanks to Raki and Asha madam for all your expert comments. And we'll move on to the next important part of this webinar, the most interesting awaited panel discussion, which is on the case-wise discussion of the fertility and endometriosis, managing the cases of endometriosis with infertility. I have the great pleasure and honor to introduce my good friend, Dr. Rekha Rajendra Kumar, who is the president of BSOG 2024 and the practicing for the most than 33 years, and has the greatest awards, lot of awards she has got, and more than 25 felicitations over to credential. We welcome you, Dr. Rekha, and we have our very dynamic young Foxian, Oxian, and our TNFOGian, and our chap from Salem, Dr. Ashwin Rao, who is a consultant reproductive medicine of endogynecology and aesthetic gynecology from Salem. And he has done his MS from Mahatma Gandhi Medical College, and his high interest in high-risk obstetrics and reproductive medicine and endogynecology. And he has more than 15 publications, both international and in the index journals. And he has been the member of ISAR, IFS, IAG, INSAG. We welcome you, Ashwin Rao. Over to the moderators to introduce the your panelists. And I have the great pleasure and honor, and it's my pride and honor to welcome and introduce Asha Madam, who has been there all through our webinar, giving a lot of insights and greater inputs with her great experience and expertise in this field as an endometriosis committee chairperson of FOXY in 2020 and 23. Madam is the past president of Coimbatore OBGYN Society. She has organized so many congresses, the important one being the Endo Insight in 2021, International Endometriosis E-Congress with FOXY and the SEUD, and the organizing chairperson of the UA FOXY South Zone 2019 at Coimbatore. And she has been the organizing chairperson of IAGE and 8th International National ESAR Conference in 2001.
Yeah, that's enough, I think.
Over to you, madam. And here Raki is also here, who is the president of the Noida Society. She's the governing council member of ICOG. She's the vice chairperson of UP State ESAR. And she's the peer reviewer of the Journal of OBGYN Jogi and chairperson of Endocrinology Committee between 2020 and 23. She has so many achievements and publications to her credential. The best being the invited faculty for more than 380 national and international conferences. And she's got the FOXY Datta Award and FOXY DS Dhawan Award in 22 and 23. Over to you, the special experts as well as the moderators, to introduce your chairpersons and proceed.
Dr. Ashwin, will you introduce the participants?
Yes, ma'am. Yes, ma'am. It gives me great pleasure to introduce Dr. Manju Singh, Director and Consultant, MJ Hospital Private Limited, Bharatpur, Secretary, Bharatpur OBGY Society, 21-22. She's a graduate from SN Medical College, Jodhpur, postgraduate from SP Medical College, Bikaner. She's undergone basic laparoscopy training in 2007 with Dr. Hafiz Rahman, advanced laparoscopic training 2012 at Ethicon Institute, AIIMS, Delhi. Training in cosmetic and aesthetic vaginal reconstruction surgery, IVF training at Rainbow Hospital under Dr. Jaideep Malhotra, and colposcopy training 2014-20 with Dr. Priya Ganesh, life member of FOXY and life member of ISAR. And next, it gives me pleasure to introduce Dr. Anil Kumar. He's secretary of the Secretary of Rajasthan Society.
Sir has put very nicely his CV.
Short and sweet.
I know. Very nice.
Dr. Richa Gupta, Senior Consultant at City Hospital, Alwar, Vice President, AOGS, Alwar 2014, Joint Secretary of Narchi, Rajasthan 2024, President, AOGS, Alwar, Member of Practical Obs and Gynecology Committee, FOXY, Member, AOGS, Alwar 12 and 17, Member of Adolescent Committee, Narchi, and experience 23 years. Field of interest is high-risk obstetrics and infertility. And she's the receiver of multiple different awards. And she's got a lot of articles published with FOXY Focus and many other journals as well. And next, it gives me pleasure to introduce Dr. Desh Deepak, Director, Rajdeep Fertility Hospital and Research Center, Kota, which is a FOXY recognized training center for endoscopy and infertility. Achievements: he was the organizing secretary of West Zonal UA FOXY Conference 2022. Organizing chairperson, State Conference of Endoscopy, AGESRCON 2019, and organizing chairperson, State Conference, Rajasthan, Raj Gynecon 2017, ex-Kota OBGY Society. His special skills are with endoscopy, high-risk pregnancy, BOH and ultrasound. He's a pioneer of advanced endoscopy and IVF in Kota region, and his credits got the first IVF baby in the Kota region. And next, it gives me pleasure to introduce Dr. Umayal Murugesan. She's the managing director of Sri Kumaran Fertility Women Specialty Hospital at Tambaram, Chennai. She's the president of Kanchipuram OBGY Society 2025, president IMA Tambaram 22-24, chairperson IMA Women's Wing 24. She's a member of the World Association of Perinatal Medicine. Her special interest is in laparoscopic and pelvic surgeries and reproductive medicine. And next, it gives me pleasure again to introduce Dr. Vanita Anban. She's the medical director of Sunrays Laparoscopic Center in Chennai and teaching faculty EISC Chennai and managing committee member of OXY in 21-23, EC member TNIAG 19-22, and coordinator of South Zone Endoscopy Committee in 21-24. And she's got multiple credentials under her name with multiple awards and several papers in the national conference as well. And then one of my closest friends, Dr. Priya Kanapan. She's a senior consultant at Dr. Mehta Hospital and GFC Fertility Center in Chennai. She's the best outgoing student and the best resident award from Manipal University. Underwent training, fellowship training in ultrasound, reproductive medicine, and laparoscopy. Active participant at Foxy Quiz Committee and conducted multiple PG quiz sessions at Oxycon, TNFOG, TAFISAR, APCon, SouthCon, VP Conference, etc. She's an active participant in the Foxy Clinical Research Committee 2023-24 with the monthly webinar club meetings. And she's a master trainer of Foxy HPV Vaccination Training Program 24, executive committee member of Oxy, and interest in high-risk obstetrics and infertility. And next, I'll introduce Dr. Madhumita Arun Karthik. She comes from our society. She's a consultant in reproductive medicine, obs in gynecology, treasurer of Salem Society of TAPISAR, EC member, Oxford, ISAR Youth Brigade member, peer reviewer journal of Jogi, editor, newsletter of Midlife Management Committee, editor, publication in charge of Public Awareness Committee, editor, official e-journal of Oxos, and assistant coordinator, online ART program, ACRM 2021. And she's organized, and she's the South Zone coordinator of Foxy Has Talent, and Miss Foxy awardee, I think it's Mrs. Foxy awardee 23, and the Foxy Superstar Award 2019, and 4 international publications on ART.
Yeah, thank you, Dr. Arun, for introducing all the panelists. Dr. Jairani, it's already 9:15, just for your information.
If you can finish by 9:45, I'll be very happy.
Oh my God. Yeah, I'm just sharing the screen. Yeah, it's seen, no? Screen is visible?
Yes, ma'am.
Okay, fine. Thank you. Thank you, experts, Dr. Asha Rao, Madam, and Dr. Aki, and also all the panelists. First of all, thanks to Dr. Ashwin for helping me to prepare this presentation. So just one or two slides just on endometriosis. As William Osler said, he who knows endometriosis knows gynecology. It's a benign disease, estrogen-dependent disease, locally recurring disease, and progressive gynecological disease, mainly of the reproductive age group, because the patients do have a lot of symptoms. They want to get pregnant. So in the reproductive age group, they come more to us compared to the other, like the perimenopausal and all that. Lot of controversies, and that's why it's called an enigmatic disease. 44% is in the ovary, under the incidence. So 25 to 50% of infertile women have endometriosis. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. Frequency of endometriosis among women with infertility subjected to, when we subject them to our DHL, diagnostic hysterolaparoscopy, we see, if you keenly observe, it is around almost every alternate patient has endometriosis. The result of IVF in advanced endometriosis is reduced to great extent, to the extent of 36%. Remember, especially the juniors who are watching, remember when you do a laparoscopy, even smallest of these white small dots or the sclerotic appearance, the fibrotic appearance, or these black spots, anything can be endometriosis, these small things. So when you do a diagnostic hysterolaparoscopy, it's very important to check all the nook and corner, all the different folds, and for these very, very small subtle things. So first question goes to Dr. Manju Singh. Madam Manju Singh, I would like to ask you, what are the factors which you will consider? This is only regarding, we are talking about endometriosis plus infertility, that's all. We're not talking about the pain management or anything. So what are the factors which you will consider during the management of the infertile couple? Manju madam. Hello? Hello? Am I audible?
Yes. Yeah, Rekha, you're audible.
Dr. Anil Kumar. Sir, can I shift this question to you, Dr. Anil Kumar? I don't know who are the panelists who are present actually, because it's all written doctor. I could not make out who are there.
No,
Dr. Richa?
Richa madam is here.
Yes.
Yeah, Dr. Richa madam, please answer this.
So the factors which we consider during the management of infertility, it depends what is the patient is and what is her reproductive desire. Whether she desired to conceive in the short term or she wants management, pain management. And also it depends upon the disease stage. What is the disease of a stage, is whether it is stage 1, stage 2, according to the ASRM classification, or it is stage 3 and stage 4. And also other presence of other associated factors for infertility, like tubal factors and male factors, or any other significant medical or surgical history.
Yeah, thank you so much. Perfect. You have answered all the factors that will cause the problem to her, and our treatment depends upon that. So now I will shift my question to Desh Deepak sir. Sir, here I am presenting you a simple case. She's 29-year-old. She consulted us for dysmenorrhea and primary subfertility for 4 years. She's been trying for 4 years, but not able to conceive. Laparoscopy was just done a fortnight back that showed mild endometriosis, and the small spots, whichever I showed in my previous slides, those were fulgurated. Hysteroscopy was normal. There was dye spill bilaterally. Tubes were patent. Ovarian reserve and the male part parameters were also normal. So almost everything is normal except mild endometriosis, what you can call as a grade 1 or grade 2. So what is your plan? How she is very eager to conceive. She is sitting in front of you in your consultation chamber. What will you do, sir? So going little ahead, will you stick on to the medical management? Will you tell her, because I've done laparoscopy, I have removed all the endometriotic spots, you can wait for spontaneous conception, or will you go ahead and advise her the controlled ovarian hyperstimulation and IUI, or even IVF? What would you think of treatment in this patient?
If both the tubes are patent, then I advise about CVH with IUI, because IUI plays a role in cases of the mild endometriosis, mild to moderate endometriosis. One thing. Second thing, in this case, she was having dysmenorrhea also. So in such cases,
Yes.
I always do excision of the all the nodules in 360 degrees. So and sometime deep infiltrating endometriosis is missed in even laparoscopy also. So we also advise MRI in all cases of the having dysmenorrhea to rule
Yes.
out the deep infiltrating endometriosis also. But in this case, I think IUI is the best option. And
Yes.
in all cases of endometriosis, we should do plan pregnancy as early as possible after surgery.
Perfect. So we do not, because we have operated on her, we don't tell her to sit and wait at home. We tell her the first 6 months is a golden period. Soon after the surgery, take advantage of that. That is what we will tell her. And in this case, since it's a mild endometriosis, controlled ovarian hyperstimulation plus IUI should be enough. And you can start with the letrozole also. Let us not go into the details of ovulation induction. At the end of this question, I'll come to Dr. Rakhi and Asha madam. So IUI, it is told that COH with IUI should be considered within first 6 months, according to many of the big bodies like AFS or American Fertility Society or ASRM. In mild and minimal endometriosis, it is superovulation with IUI. So increase about 10 to 15% success rate and continuously do it for 3 cycles. If patient insists, go for 6 cycles, and that should be enough. So the statistics wise, higher live birth rate with COH plus IUI is 15% compared to not doing, which is 5%. Letrozole or CC, almost same results. You can go for FSH and HMG, which will give still more better result. And all of us know, also the previous speakers mentioned that endometriosis reduces per cycle conception rate. Now, Dr. Asha madam, do you want to add anything here?
No, I think you are quite a bit on the right track, because she is, mild endometriosis, fulgurated, tubes patent, male factor, all right. So normally I would give 1 or 2 cycles of timed intercourse. If it doesn't happen, I would definitely go in for IUI.
Okay, thank you.
Yeah,
Dr.
that's fine.
Rakhi?
And not too many cycles, maybe 3 to 4 cycles.
Yes, madam, correct. Dr. Rakhi, can I have your inputs? Dr. Rakhi? Okay, we move on to the second case. We have divided our cases, myself and Dr. Ashwin. I'll move really very fast because there is no time. This is a second case. She's little bit old. Previous one was around 26, 27. Now she's 36-year-old. I'll talk to Dr. Umayal now on this case. I'm discussing with Dr. Umayal. 36-year-old, primary infertility, married for a decade. Since it's been 10 years and she's getting old, she's very, very keen and upset that she hasn't got pregnant. Tubes are fine, male factors are fine, everything. She, as a part of infertility profile, investigation profile, transvaginal scan was done 2 months back. And unfortunately, it was little bit big only, around 6 centimeter, one-sided. That's right ovarian endometrioma. AMH is borderline, Dr. Umair. Now
Yes,
what
madam.
will do for this patient?
Yeah,
Thank you.
yeah. So this is a patient who has been married for 10 years.
I have put here, different
Yeah.
options I have put here.
Yeah, so then since the size of the endometrioma is quite huge, I think we will have to go and do a surgical management for this patient. Laparoscopic ovarian cystectomy would be nice for this patient. At the same time, we can also do an evaluation of her hysteroscopic evaluation of the uterine cavity as well, and the opposite tube as well. When you just come out, patency also can be checked after the surgery is over. And one thing is like we have to use very little energy sources because already the AMH is very less. So if you use too much of energy, her AMH will further reduce. So we'll have to very judiciously remove the cystectomy with using minimal fulgurations and minimal energy sources. And simple activities like applying pressure over the cyst after the removal of the cyst itself will control the bleeding, if at all there is any. And then followed by referring her to an infertility specialist and advising her to go for advanced procedures like IUI or even IVF may be better in this case.
Thank you. But there are a lot of debate going on whether in these kind of cases we have to remove the endometrioma in spite of being 6 centimeter, that is big only, whether we have to remove or not. There is a lot of debate, and let us talk about the certain yes or no's of this in future slides. So if we decide to do laparoscopy, Dr. Vanita, I'm with you here. If we decide to do laparoscopy, as Dr. Umayal's thoughts, and we have taken her for laparoscopy, what are the advantages of laparoscopy in this woman? Dr. Vanita, are you there?
Yes, ma'am, I'm there, ma'am. The advantages, as Dr. Umayal, madam, explained, would be to get a cystectomy done, restore the tubo-ovarian anatomy, also fulgurate the superficial endometriotic deposits that are there. And also we could have a chance to look at the hysteroscope findings and see how they are. At 36, married for a decade, we wouldn't really think, because once she's got an endometrioma, she's of this size, she's going to be a candidate for IVF. So we are not going to be really bothered about the tubal patency to check and put her into the category of IUI. So this gives us an advantage. But again, there is a debatable situation like when the AMH is very low, whether we have to really send her to the fertility specialist first and try to retrieve eggs as much as possible. If they are of good quality, yes. Or then do the surgery and then do it. It again depends. We have to work synchronously with the fertility specialist because our aim is to make her conceive and get her baby. So it's not that just because I'm an endoscopic surgeon, I get the patient, I just go ahead and do it. She has to have a consultation with the fertility specialist also. And we need to work together to see if we are able to get a good harvest of eggs, do that and then take her for cystectomy, or do the cystectomy, give her adequate time. And as madam mentioned, use the least energy source, the Donas technique, usage of vasopressin. All these come to help to reduce the amount of bleeding, and also the follicular wastage happens the bare minimum there. That way, we could really conserve. And the most important thing is no waiting period after the surgery. Once the surgery is done, we have to either send her for fertility treatment or keep her under control with the medicines. Not that they do the surgery, go rest for 6 months.
Okay, so you are of two thoughts, unlike Dr. Umayal. Dr. Umayal straight away wants to subject her for the surgery, that is endometrioma surgery, whereas you think of probably either of the two, right? That is,
yes,
either
because she's
surgery first,
36 and her AMH is very less. If it's really going to drop down very much after the surgery, maybe she should have to go for a oocyte donor. So it's better we consult with a fertility specialist, discuss the options with her, and give her the right to choose what she wants.
Perfect, perfect. Yeah, this is the entire list I have placed here regarding the advantages of the laparoscopy.
Most of the time, when we do an TVS in such cases, the antral follicle count actually will give us a better picture of what we need to plan in future, because many times we see low AMH, but clinically we happen to see some good oocytes. Maybe we can develop on them. So a good TVS will really help us to take a call on such cases.
Yeah, you are right. And we are coming to that. Okay, laparoscopy is the first line of treatment. As Dr. Umayal said, it is not wrong. It's a difference of opinion between the two surgeons. So any endometriotic implant seen during laparoscopy is taken care of. And cumulative pregnancy rate slightly increases following laparoscopic surgery and then subjecting her for IVF-ICSI than IVF-ICSI directly, according to certain studies. So these are all the things which I have mentioned, like the surgical ablation, all these things. Because there is no time, I'm not going to detail of this little bit of statistics on laparoscopy. Now, can I talk to Dr. Priya that what are the indications for the surgery? Like, agreed that 6 centimeter endometrioma lady.
Actually, like for a 6 centimeter endometrioma, I mean, with the AMH of 1.1, I'm not yet worried because it is much better. Because most of the time we just see a AMH of 0.3 and 0.4 where we really think that, okay, you have to go for direct IVF. I think 1.1, I think you can still go for laparoscopy. That is one. And as you have already mentioned, there are other advantages. One is that the quality of the oocyte gets definitely compromised when you have an endometrioma and go ahead with stimulation. So it is better to get that, and the inflammation, once it reduces, it definitely has a better quality oocyte and better pregnancy rate. So in this case, I would have preferred to go ahead with the surgery, and because it's not a recurrent surgery. For example, if the primary, she's not operated at all, and she's come to me with a 6 centimeter endometrioma, we would definitely advise her for surgery followed by ART will be the first choice. Other than that, if a patient is symptomatic, for example, if she has severe pain, dysmenorrhea, dyspareunia, or even a small speculum, even an embryo transfer can be extremely painful for the patient. So in those patients, even TVS can be extremely painful. So those patients, definitely surgery will be the better choice for them. And the other thing is any size. Previously, we used to say a size of more than 4 centimeters, but now we say even a size of 3 centimeters, better to go ahead with surgery and then think of that. And definitely, while doing a TVS, every ART specialist will be able to pick up whether, the pickup is going to get hindered with the endometrioma. If it is there, sitting there, and all the other follicles are behind the endometrioma, like you don't have a plane or a place where you can negotiate and go, it is better to, handle the endometrioma with the surgery and then plan your ART. So those are the things where we will really think
Priya,
of.
there is a small confusion in what you said. Maybe you spoke rapidly. Earlier, ESHRE guidelines said that size more than 3 centimeters should be excised. But the current ESHRE guidelines say that this word 3 centimeters is removed. Any size you need not remove. This is what the ESHRE guidelines say. The size itself is removed. It's only the paper where Sumagliana says that more than 4 to 5 centimeters are cut off. But according to ESHRE guidelines, even they have removed the dictum of size.
Yeah, which
earlier ESHRE said more than 3 centimeters remove. The current ESHRE has removed that word size. So unless there is pain, inaccessibility of the follicles, or suspicion of malignancy, you need not remove the cyst. This is what the current guidelines are saying.
Yeah, exactly. Nowadays, even if it is 6 centimeter or beyond, the fertility specialist will see whether they can negotiate, in the sense whether they are able to do OPU without touching that. If that is the case, even 6 centimeter, they leave it like that. They prioritize on making the embryos. Isn't it, madam?
Yeah, this is just to correct the notion about the guidelines.
Yeah, okay. Thank you, madam. Thank you for your valuable input. Okay, now, Dr. Madhumita, should all endometriomas be excised before IVF-ICSI cycles? Probably that is what was partially answered.
So Madhu is not here. Madhu is not here, madam. She has gone for an emergency.
Fine. Dr.
Manju. No need actually to remove all the endometriomas. Not at all necessary. Depends on this.
We said,
and where there is any complaints, like any other complaints for the patient, if she has severe dyspareunia or she has any bladder or bowel symptoms, then maybe doing the surgery and then proceeding might be of help. Otherwise, for IVF management, if there are sufficient follicles, it is best you go stimulate, remove, do the egg. And if you really have any issues before the embryo transfer, if you feel that the cyst needs to be removed, then you can do. But ideally, stimulation, getting the eggs and creating the embryos and then proceeding will be a better option. For
Yeah,
most
here
of
again, I see that the guidelines are from 2006. The previous slide,
Yeah,
whatever statement we
RCOG
have done is from 2006.
Yeah, yes. But
And so
later on,
much has changed in the last 18 years. If you can just show that slide.
This one, madam?
Yeah, the lower paragraph.
That's why
is
I
a
wrote
guideline of 2006, which has been discarded completely.
Yeah. Fine. Okay. That's why I wrote it
According
as
to the new guidelines, there is no need to remove endometrioma. If there is no difficulties in oocyte retrieval.
Yes.
Ideally, if it is not coming in the way, don't touch it. Do
Don't
ovum
touch it.
pickup.
Yeah.
Retrieve as many oocytes we can, M2 oocytes. Preserve them, make the embryos and preserve them. If you feel we are not able to transfer, freeze them and then do the surgery.
Exactly.
This is the first line of management.
Making embryos is our priority, isn't it?
Yes. Pain is the only indication currently for to go ahead
Because
with
with
the surgery.
Rekha, with endometriosis, every 2 years, I think something is changing. What was true yesterday was not true today.
Yes.
When we are doing ovum pickup and cysts are obscuring our vision, then we can remove at the same time laparoscopically.
No.
Because there is chances of release of
One of it. If
toxins.
you are touching the endometrioma, you are ruining up the whole cycle.
But of late, Rakhi, I read a paper in fertility sterility where they mentioned about egg collection and dermoid cyst removal at the same time.
After collection, after you're satisfied completely.
No, that's what I'm saying. What was true yesterday is not true
Dermoid
today.
cyst is different, Dr. Asha. Dermoid cyst is something different which you can touch it, you can do it. But endometriosis is totally a different game ball.
No, it's possible that maybe after 1 more year, something will change again.
Something can come up, definitely. The science is
because it's changing every year.
It's
maybe
changing
the follicles which are
very
inaccessible vaginally, perhaps you can pick up by laparoscopy and then go in for a cyst removal to avoid abscess formation.
Yes.
That may come after 1 or 2 years.
Every time. Yes. Dr. Manju and Dr. Anil are not there, no? Okay. Dr. Richa, I'll come back to you. Now we have the patient has this cyst that is big, quite big one. You have decided, as we discussed just now, we decided to go for oocyte retrieval in spite of keeping the endometrioma there and not operating on her. Now, what are all the difficulties you will face during the oocyte retrieval?
This oocyte retrieval may be difficult because of the cyst, and we should, as already said, we should avoid to touch the endometrioma, because if it is touched, there can be release of toxins or follicular fluid contamination, and there can be chances of infection or cyst formation or abscess formation.
Yeah, thank you. That's right. Presence of large endometrium at the time of pickup significantly reduce the number of oocytes retrieved compared to the healthy ovary. And ovarian endometrioma reduces rate of ovulation. There are, again, as Asha madam said, lot of papers with the difference of opinion also and keep changing every time. So ovarian endometrioma reduces rate of ovulation in contrast to normal ovaries, almost half. What are the disadvantages of the surgery? You've decided to do the surgery. We said that there are a lot of advantages also in the previous slide. Are there some disadvantages also, Dr. Desh Deepak? If so, what are all, we are talking about only the laparoscopic surgery. If so, what are all the disadvantages of the surgery?
Main disadvantage of the surgery that after
for
surgery,
the infertile patient.
There is chances of the reduced AMH, but when we do meticulous surgery, like don't use any energies and use vasopressin. So in such cases, I think after 3 months of the surgery, again the AMH is improved. So
but
I
depends
think
upon what kind of
good
surgery you're
hands
going
surgery is having the advantage. I'm in more favor of the surgery. Good endoscopy surgery will increase the AMH level after some time also.
Agreed, but it
The
depends
most
upon what
important
kind
thing
of
is
surgery.
In
But at the
surgery,
time
no,
of
there are
surgery,
still
more surgical approach based on the evidence and healthy orient tissue removed by stripping of the cyst wall. Basically, we should recognize what is the healthy tissue, what is the endometriotic tissue. So always try to preserve the healthy tissue and use judicious use of energy sources is very important. Don't use the even energy to the ovaries.
Yeah,
And
all
surgery
those
goes
what
to
I
the
have
ovarian
mentioned.
hilum should be avoided. That is a very
Yeah.
important point.
Yes, yes, perfect. So if we have decided to the surgery, it should be a minimally damaging surgery. We should respect the tissues, especially the ovarian cortex. We should really take care of, as you have mentioned. In spite of that, many studies have shown that in spite of doing all the whatever you told, that there will be the specimen will contain some healthy follicles also, isn't it? So the surgical excision gives satisfactory pregnancy rate. The concern about removal and ovarian reserve is there. And about this lap cystectomy before this, that is IVF, does not appear to improve. These are the ones where they say that they don't want to do the surgery. Asymptomatic endometriomas may be better directly taken for IVF ICSI, as what we were telling just previously, than taking her for surgery. So these are the points in favor of not doing the surgery, the disadvantages. So putting them in nutshell, to operate, there are certain aspects, that is the certain advantages. Not to operate, there are certain things. Regarding surgery, doing the surgery, better success rate, prevents rupture, facilitates oocyte retrieval, avoids contamination of the fluid. You will have the histopathology and you prevent the progression. When you don't operate, again, you think in the positive way is cystectomy prior to IVF does not improve the pregnancy rate. The surgery and anesthesia risks are there, reduction of the reserve, as you mentioned, and aspiration, yes or no, because high chance of recurrence. It is just a very temporary measure. Now, Dr. Asha, you want to tell something, add something? Asha, madam?
Yeah. Sorry. What you said is very much right, Rekha. Number one, presence of cyst can reduce the number of follicles or oocytes obtained. Very much agreed. Number two, when you do a surgery on this cyst, the number of oocytes obtained can decrease further. So initially there is an insult by ovarian cyst and later there is an injury by surgery. So a combination of presence of cyst plus surgery can reduce the number of oocytes further. That's how now more and more we're trying to avoid surgery. And it has been shown that though the number of oocytes is decreased, the
quality
live birth rate is not really decreased.
Yeah.
This is a complete about turn today. Today, the research does not agree that the number of pregnancies in endometriosis are less. Though the number of oocytes is decreased, the pregnancy rate is similar. Implantation rate is similar.
Okay, fine, madam. Dr. Umayal, what are the indication for IVF ICSI in endometriosis? It is not just the endometrioma, right? There are many other factors also where you want to take that patient of endometriosis directly for IVF ICSI. You don't want to settle for any lesser treatment like IUI and all that. Which are those cases? Dr. Umayal?
Umayal, unmute.
No, she's unmuted only, but she's not talking.
No, she's not unmuted. She's muted.
Okay. Dr. Umayal?
Yeah, madam. Tell me, madam. I was just on. I was few seconds off the radar. Tell me, madam.
Fine. My question: which are the patients? One indication is endometrioma, agreed. What are all the other factors you will consider where you will directly shift her to IVF ICSI, endometriosis patient, definitely, and not settle for lower level of treatment like IUI, wait for some time, natural, medical treatment, etc., etc.
For
Direct IVF.
Yeah, direct IVF, especially the number of years she's been married is more. The AMH is very, very low. If there is an associated male factor and there is any other associated factors related to the women for whom you are going to do the treatment for all these cases, no, like instead of going, first thing is low AMH. That is very, very important. And if there is a male factor, then definitely this and this, the female and the male factors compromise. Better we allow them to go for an IVF directly instead of allowing them to do all those steps for these cases. And
Yeah,
any other,
bilateral,
yes.
yeah, recurrent endometrioma, bilateral endometrioma, and adenomyosis also add to
Adenomyosis.
the list. Yeah.
Adenomyosis also treat them medically maybe for 1 or 2 months. You collect the eggs, you collect the eggs, create the embryos, then you can give them some medical management like agonist or even Marina. Sometimes we use for adenomyotic uteruses. Then we, after 3 months or 4 months, then we take the healthy embryo and put it into a healthy uterus. So that way the results are much better.
Okay, thank you. Dr. Vanita, in the present era of every alternate case landing up in medico-legal issues, I'm very sure you agree with me that counseling is very important in these dicey situations, isn't it? So when you counsel these kind of cases, what are all the points you talk about? What are all the medico-legally, why counseling is very important in these cases, and what do you emphasize on?
We need to make them really understand in endometriosis per se, the fertility is going to be less compared to normal patients. So the surgery is going to be a fertility enhancing surgery, but not going to guarantee her saying that she's going to have a baby at all means. The quality of oocytes are going to be less, and we need to really give her the realistic prognostic value, and we should not give her any tall promises, and everything should be on return mode, explaining to her the risks associated during the surgery in terms of the reduced antral follicle count and the AMH values that are going to happen. And we need to also tell them that, as you really rightly said, when we strip the cyst, there are normal follicles also which are going to go away, and they can be reduced, but they cannot be totally overcome. So these things have to be brought to mind, and we are just only doing a fertility enhancement, and we are not really going to guarantee saying that after this surgery, this particular patient is going to take back a baby home, because the other factors may also come into influence, like the male factor and other things. All this has to be very clearly discussed with her. When we get a endometriosis patient, especially a superficial endometriosis, okay, when we talk of endometriosis, we talk of 3 things. One is superficial, deep, and the ovarian. So when we get a deep infiltrating and the ovarian endometrioma, I think we need to really take time in our clinic, explain what is the realistic projection that we have on these patients, and we also should do a cost counseling to them. We should also talk about oocyte donor in case they really require one, and we also need to tell them they may not conceive in 1 or 2 cycles, they may even extend beyond that. All this needs to really come.
We also tell about the recurrence of the disease also.
Yes, 2 things we have to, other than that.
And one more point is like try to avoid surgery as much as possible. Second, if at all the patient needs a surgery, we need to get the surgery done by a real expert. The surgical skills also matter.
When we talk of surgery, we are not talking about cyst drainage. That's totally gone. So we still find patients who just get a cyst drainage, come back within 2-3 months with the same size sitting there. And we really cannot call them as a recurrent endometrioma, because when we go through the notes, they've just undergone a cyst drainage. So the least thing that we need to do for a patient is cyst excision.
Agree. But in spite of that, recurrence is known, in spite of thorough surgery, we have to explain that. And second thing is a pre-op estimation of AMH, because already these patients have low AMH, and they should not blame you if you do the AMH estimation post-surgery, saying that it is because of you my AMH has come down. So do that and show to them that your AMH was low. So these are the additional points which I would like to add. And as you said, there are conservative surgery. There is an entire list of the conservative surgery. We are not going to emphasize on these surgery, not the first ones in front of the patient we keep as choices. They are just very temporary, very rare situations we'll opt for these, like incision, aspiration, diathermy, ablation, just wash, and all that. So these are not the real surgeries. All the above have very high risk of incomplete surgery or the recurrence, and excision and cystectomy are the only surgeries. Here what I put is one side ablation and one side cystectomy. The summary of this is saying that ablation is the one that is better, in the sense lesser loss of primordial follicles, because we are not going to use lot of diathermy. I mean, we are using higher risk of recurrence because this wall is not entirely removed and we are just doing the diathermy part. Whereas cystectomy is a complete cyst wall removal. So it is completely excised. So fertility may reduce. Diathermy is less used. And there is because of the stripping, there is more loss of primordial follicles. But recurrence rate is less in cystectomy.
That is where the acquired dissection technique by vasopressin really helps, madam. And
Yes.
Creating proper planes and adhering to the planes really helps.
Yes, yes. Remove the cyst in the proper plane. So cyst aspiration, we are not happy. What are the limitations of the surgery? I'm talking to Dr. Priya. Dr. Priya?
So limitations, actually, everybody has told already, madam, there is a high risk of recurrence. So, like in spite of doing a complete surgery, doesn't mean that, she will not have recurrence. Some patients can have it because we'll not be able to give a complete surgery always. There can be few things where it is, like near the essential structures, we are going to leave behind certain things and that is going to cause some recurrence. So that is there. And the more years, like, they are going to, like, be without conception, then the chance of recurrence is even more higher. So that they should understand. And definitely pain will be like, pain is now the main criteria when the patient is having endometriosis to consider surgery. So that we can always tell them the pain will be reduced, but you cannot again give them 100% sure that it is there. And sometimes the inflammatory and as we said, the gut microbiota, everything is altered. This cannot be like, completely sure that everything will come back after the surgery. So again, we cannot give them all this, that, okay, everything will be normalized. You're going to be a normal non-endometriotic patient after surgery. So that assurance we cannot give them. And nowadays, we don't give them a post-operative medical treatment. I don't think it is recommended nowadays. We just want her to conceive as early as possible. So long-term post-op medications are not recommended nowadays.
Thank you. Dr. Richa, what are the situations where the surgery is better avoided? You don't want to do surgery in these kind of patients, and which are those patients? The very beginning of this panel
better is the first is the symptoms, asymptomatic patients. We should avoid this surgery. And age, we should taken care of the age. And there is older patients because this is a very vast surgery. And if we want to preserve the fertility with the less AMH, we should not touch this endometrioma. And in cases of bilateral endometrioma where patient want to preserve fertility, and in recurrent cases, we also avoid the surgery because there is always a chances of recurrence. And if we want to do surgery, we have to focus to remove all the disease, and we should the surgical skill should be better. Because if we will not able to remove all the disease, there will always be recurrence.
Yeah, very perfect. This is just in nutshell. I'm not going into detail of this. This is benefits of expectant management versus surgical and risks of expectant management versus surgical. Whatever we have discussed so far, everything in nutshell. Now coming to Dr. Desh Deepak sir. Sir, what are the precautions you will take when you are doing the OPU egg pickup, having that huge endometrioma there? When you are the procedure, OPU procedure as such. We have discussed what are all the problems like the follicular fluid contamination, all the things we have discussed. The technique wise, how will you manage? Desh Deepak sir.
Sir is not seen, madam.
Okay, fine. So I will.
Sir is there. Sir is there. Sir is there.
Fine. So Desh Deepak sir, can I ask this question?
To be taken during OPO in the presence of endometrioma.
Yeah, the procedure as such.
Yes, madam. We should not puncture the endometrioma basically.
Yes, perfect.
If it is punctured, then a good antibiotic should be there. Even I have faced one abscess also when it was punctured. So even before doing ovum pickup, we should see first we should do the transvaginal sonography, and we can see that whether it will not come on the way while we are picking the ovum. So why to do pickup in such cases if the endometrioma is coming first in our biopsy line?
Yeah, correct. Other than that, the antibiotic prophylaxis before the surgery, betadine wash followed by thorough saline wash. asepsis, because blood is needed for infection. Repeated needle in and out should be avoided. It should be in the ovary, and through that you have to keep doing aspiration of the follicles. Avoid puncture and aspiration of the endometrioma, as you said. Now, can I hand over the mic to Dr. Ashwin Rao for the further cases of Dr. Ashwin?
Thank you, ma'am.
Yeah.
Ma'am, Jerry, how long do we have to have remaining?
I'm trying to finish very, very fast.
Yeah, it's almost maybe
No,
another
it's not
5 minutes,
much.
10 minutes.
But we started at 9:15. It's not even.
So I'll go ahead quickly. Not much of bibliography with my cases. Mrs. A, 32-year-old female, software engineer, married 5 years, nulliparous, with regular menstrual cycles and severe dysmenorrhea since adulthood. Her complaints are recurrent episodes of cough, chest pain, shortness of breath, which occur cyclically around the time of a menstruation, and she reports mild hemoptysis as well. So if I can get Dr. Richard to say something about this case, what do you think could be the probable diagnosis?
Your history is continued in this page also.
Oh, thank you, ma'am. That's not it came in. Okay, describes pleural chest pain, and each episode lasts 3 to 5 days. No fever, tuberculosis, or any recent infections. Dysmenorrhea significantly affecting daily activities. She underwent lap cystectomy 2 years ago for an endometriotic ovarian cyst. What do you think could be the diagnosis, ma'am, and what would you like to do about this?
It is a case of endometriosis, and there is outside the, but it is a maybe the lung endometriosis, and because this is already the patient is having endometriosis, history of endometriosis surgery. And in this case, we have to investigate, we have to do chest X-ray or CT thorax, or in the MRI, we will also see the multiple endometrial deposits, and we can do bronchoscopy to see the lesions. And in the blood level, the CA-125 level will be mildly elevated. So it is a case of endometriosis.
So this is a case of pulmonary endometriosis.
Pulmonary endometriosis.
Yes, ma'am, yes.
Plural.
So if I can have, I think Vanita was trying to run away. If I can have her to
No,
have
no,
a
no. There's no
question.
charge in my phone, so I'm just getting to try that kind of get connected.
Okay, so I know you're an endoscopic surgeon, ma'am, but a few points on the medical management, if possible, on this particular scenario.
I think anyway, extrapelvic endometriosis really doesn't work much when you treat them medically. It is just an empirical treatment that you give to see if the pain gets relieved and suppressed, or if not, then I think surgeon takes over.
Okay, ma'am. So surgically, so here coming to the fertility part, this is one of my cases which we handled a little differently. The same case, pulmonary endometriosis, we handled a little differently because the patient was unwilling to undergo a wedge resection of the lung because she had multiple deposits in different parts of the lung, as you saw in the CT image. So she refused. So she was willing for medical management. So she was given medroxyprogesterone in this particular part for a long. Ma'am, can you go to the previous slide, please? So in this case, this patient had an AMH of 1.9, FSH of 10.3, LS 0.2, and day 2 AFC of an aggregate of 8 to 9, both ovaries combined. Ma'am, next slide, please. So this patient was on long-term medroxyprogesterone state. And this is probably what we did because the patient was already on the already in medroxyprogesterone state. We went for a PPOS protocol and then we obtained 4 blasts. And since all of you are quite senior in your fields and all of you are experts as well, do you think that I should have handled this case a little differently? This is something I published, but do you think I should have handled it a little differently, or do you think it was okay? So, ma'am, can we get an answer from?
These are some cases which one may not even encounter in their entire career, or maybe you may come across once or twice. It's not one person bound, it's always a team approach, and then you decide on. I think you did the best at that point of time, whatever came to your mind, and you were almost got whatever she wanted. You've given her pain relief, and you've also given for a baby. So I think that way you're always right, Ashwin.
Dr. Rakhi, we can have your input.
Yes, and for my experts, please. Rakhi ma'am, please.
Dr. Rakhi.
Very rare we see such cases, Ashwin. So it is an interesting case which will not come across in a routine practice over a period of 30 years. I haven't seen any patient with your lung. Maybe you are fortunate or the patient is fortunate to come to you. I think you have done the best thing. It is one of the interesting one, which is not a usual practice. So as a differential diagnosis, we
What
think of
about her hemoptysis and whether the symptoms relieved after
The moment, the
pregnancy?
time she delivered, her pregnancy lasted for about eight months, and then 6
quite
to 8.
natural. All this will get regressed once
And
she's
everything
pregnant
went
and
away. And
all the
then
progesterones comes into a role.
Yes, ma'am. Then she
Rakhi
regained
is there?
cycle. And
After
Asha ma'am or Rakhi ma'am?
after delivery, after delivery, patient have recurrence of symptom or not?
Oh, ma'am, the symptoms kind of resolved altogether because she had amenorrhea for close to 16 months because antepartum and postpartum together.
Okay. Thank
So that's why we thought of publishing this, and it got accepted in a PubMed journal. So
And I
thankfully,
think the words in
I think,
Juha's
Ashwin,
textbook
it's
comes
a
through.
wonderful management. Ashwin, you have
Yes,
done
ma'am.
very well. I have not seen a case like this at all. So you are very lucky to get one case like this and you managed it so well.
I think the words in Juha's textbook comes true because they say the pregnancy is the best treatment for a person with endometriosis.
Exactly, ma'am. Yes. The best thing that you can do is give her pregnancy. You kind of hit two birds with one stone. You kill the endometrios, you give them a pregnancy as well, and they're happy with you for life.
Yes.
But some endometrioma can enlarge and mimic even a malignancy, especially the decidualization of the endometrioma. So there's the only condition where the ovary can enlarge during pregnancy.
Okay. Can we move on to the next case?
Yes, ma'am. Yes,
Ashwin?
ma'am. Case 4, that is Mrs. A, 32 years, married 4 years, unable to conceive for the past 2 years. She's got regular cycles with moderate flow with severe dysmenorrhea needing NSAIDs. She was diagnosed with endometriosis 3 years ago. History of laparoscopic ovarian cystectomy for bilateral endometriomas at about 3 years ago. So how would you like, she wants fertility management and she wants to conceive. So any idea how you'd like to go ahead with this? Dr. Priya Kanapan, please.
So can we, in this patient has already had a endometrioma excision.
Yes.
So,
and now she's recurred now again.
Yeah, so for recurrent, usually, if she's asymptomatic, we definitely not prefer for surgery. And the AMH is already on the lower side, but the endometrioma is 3 centimeters and 2 centimeters, right? If I can see that, these are the tests. So I think we'll directly, convince her for the ART, and we have already discussed in last cases that we will not, waste more time with her, and definitely not a recurrent surgery for this patient.
Ma'am, would you prefer, one slide behind, please, ma'am? Would you
So,
prefer to give her
can I add one more thing?
Yes, ma'am. Yes, ma'am. Always, ma'am. Yes.
Such patients, they can be benefited with the sclerotherapy because nowadays we come across a lot of sclerotherapy which are being done for such endometriomas who have been operated once or twice. We give them a sclerotherapy and then proceed with the your stimulation and oocyte pickup. They have a better improvement because the pain is less. Your chance of injuring during the collection, the difficulties and all the contamination by this all will be getting reduced by your sclerotherapy. Because there are a lot of papers coming on this, and this has been one of the approved treatment that we give for this type of a recurrent endometriomas who have failed or coming after the surgery.
Yes, ma'am. This is the answer I was looking for. Actually, thank you so much, ma'am. Actually, because
but take a consent from the patient about possibility of occasional ovarian abscess.
Occasional ovarian abscess. Yes, madam.
Take a consent
and recurrence.
Yes, ma'am.
Yeah.
So ma'am said sclerotherapy. Any difference of opinion, Dr. Desh Deepak? Sir, any ideas?
Dr. Desh Deepak?
I have not tried the sclerotherapy, so I can't say anything. But because AMH is very low, so then we have to counsel this patient for the donor oocyte program also.
Yes. So that's another option that you should think about. Thank you, sir. And then, ma'am, if we can include Janani ma'am also into the panel, since we are missing a few panelists now. Ma'am, any pre-IVF counseling and optimization you would like to prefer? As sir said, OD cycle is a good way to go ahead is one thing. But if the patient wants only self cycles, then anything else you would think about, ma'am?
whom you are asking?
Ma'am, this is actually for Jinani ma'am because we're losing.
Okay,
We
okay,
have
fine.
Okay.
Richa ma'am who
So,
left us now, ma'am.
So as it is, when we are coming across such low AMH with a multiple
Self-cycle,
endometriotic
own
cyst,
self.
we always, with their own eggs. Probably, as I said, sclerotherapy, I'll go in and then I will go for a dual stimulation, because sometimes immediately the dual stimulation, because we want to have the time for most collections should be very less, because we want more to collect within more time, because there is always a recurrence. Once you leave her, the next cycle she will be coming with a hemorrhagic cyst again, going for an endometriosis.
Yes.
So we always prefer to do during the first oocyte pickup, we aspirate the follicles which are there. I mean, aspirate the endometriomas, remove it, and then immediately go for a dual stimulation. This will give us the time to get more oocytes will be less. So dual stimulation I prefer for such patients, because leaving her, she will have a recurrence, her AMH will be still more low, and we'll have a lot of other difficulties of getting into pain and discomfort the women face. So they will be much benefited with the dual stimulation, collect more oocytes, and then give them a pain relief and treat them with the GnRH agonist, and then we transfer in subsequent frozen embryo transfer. They have a better pregnancy outcome.
Thank you, ma'am.
You have to tell them about, as Dr. Jairani told, more number of stimulations, either dual stimulation or embryo pooling. Ultimately, we want to have more embryos. That is one aspect you have to tell her. The second aspect, what we have to tell her, that in spite of giving very high doses, we may not be able to succeed in our getting the quality embryos also, because by around say 8 or 9 days of stimulation, you would have spent enough amount of money from her, and if she's hell bent on getting the self embryos, there it may cause problem for us. So in spite of going half the way through,
Rekha, I just want to have a little difference, because the latest research papers, they said that there is no quality of the embryos are not being affected by the endometriosis. That's the latest guidelines says. There is endometriosis in the yesterday guidelines as well as in the latest guidelines. They say the endometriosis quality is not affected. The oocyte quality doesn't have an impact. It's a good practice point they've given. So don't.
And Rekha, to reduce the cost, you can try
Yes.
a combination of letrozole and low dose HMG.
Yeah,
So
I'm
don't
not
spend too
talking
much
about that.
money.
Yeah, agreed. What I'm
That's
saying
the best way. Yeah.
Which is better than high dose HMG.
Yes, cost is one thing, but what I'm saying is her disappointment part.
Ma'am, Vanika, next question to you, ma'am, because you saw the ultrasound, both the ovaries are right behind the uterus, and we saw that we saw a few antral follicles behind the endometriotic cyst. Would you still agree with when going with Rekha and saying down regulate and then do a pickup, or would you think of removing the
It
cyst?
depends on the fertility specialist. If they're able to access and smartly pick up the oocytes, fine. If they have inaccessibility and the pain factor is also there, we would still consider to do a repeat surgery and then take. The only indication for operating on a recurrent endometriosis is pain and then inaccessibility of the oocytes.
To be very frank, when an endometriosis patient comes, it's very easy, because they will be all be stuck in the back. So it is easy for us to access. Whereas if it is a mobile ovaries only, it is very difficult. It will be sitting over the top of the uterus.
Pre-induction, when you do the ultrasound before the
Ashwini, I would
induction,
like to add one thing.
the ovaries
Ashwini.
Yes,
look
ma'am.
bigger.
Yes, ma'am. Yes,
But
ma'am.
when you do it before the pickup, the oocytes look really big and accessible.
Yes.
I would like to add
something.
something.
Yes, ma'am.
As soon as you are planning for the IVF for this type of patient with a recurrent endometrioma, first and the foremost thing, if you are stimulating, counsel the patient that we may not get any embryos, any
This is exactly what I told.
It can be a possibility, though as it is her AMH is 0.8. So with 0.8 AMH, when we are stimulating, first thing we may not get the oocytes. And even if the follicles are there seen, there are every chances that we, while extracting, we may not get. Third possibility is, even if you've got it, they may not get fertilized or they may not be of a good quality.
Exactly.
These are the three big possibilities, and do counsel them that you can have to go in for, as sir has told, the donor oocytes. That would be the best way out. Tackle the ovaries and then go in for a donor oocyte. That would be the best, because with such big endometriomas, ovarian cysts, chocolate cyst, you will not be able to transfer then also. You will have to tackle that, you will have to remove that and then only transfer. And while you're doing that, obviously you're not going to get any of the oocytes. With 0.8 next surgery, it will drop down to 0.2.
Yes, ma'am. As we said, this is what happened in this case, ma'am. We added all the masala and the bel puri and everything to this, and then still we did an antac cycle and we got nothing out of it. Ma'am, can we go to the next slide, ma'am?
Yes, yes, I'm doing that. Especially those women who are very particular about the self
Maybe in
side.
another 5 minutes, I think we'll wind up.
Yes, ma'am. Yes, ma'am. So this is what happened here. Initially, we did an antac cycle, got nothing out of it. Then we gave low-dose OCPs for 4 months. And then we did 2 long agonist cycles. And then first cycle gave us one expanded blast and 1 early blast. The second cycle gave us 2 expanded blasts, transferred, and pregnancy or ongoing pregnancy going on right now, ma'am. So this is what happened, ma'am. As we had already discussion, we just go to the next case, ma'am.
This you will just continue talking, no questions. You just explain this case.
Yes, ma'am. Yeah. So in this case, Mrs. PV, 34 years, married for 7 years, nulli gravida, cyclical pain with bloody discharge from the lower abdomen wall scar for 6 months, desire of future pregnancy. She underwent open myomectomy with ovarian cystectomy for an anterior wall intramural fibroid of 6 into 7 centimeters and a left endometrioma respectively of size 4 into 5 centimeters. So post-op was actually uneventful and she had regular cycles, but still she continued to have moderate flow with severe dysmenorrhea. The current symptoms when she came to us was a progressively enlarging painful nodule at the previous scar site, cyclical bloody discharge from the scar worsening with menstruation, deep pelvic pain during her cycles and dyspareunia, no history of bowel or urinary complaints. She had no history of tuberculosis, PID, or chronic infection. So what do you think could be the diagnosis in this? And
scar endometriosis.
Yes, ma'am. Scar endometriosis,
and
yes.
something else. And something else.
So we'll come to that further, ma'am. And so in the ultrasound, this is one clinching factor. There was
a fistula. Otherwise, they don't bleed outside.
Yes,
Usually, scar endometriosis bleeds inside only.
Exactly.
Yes. So here what happened was we had a heterogeneous hypoechoic mass of size 2 into 2.5 centimeters in the anterior abdominal wall near the scar. And there was a hypoechoic tract extending from the uterus to the anterior abdominal wall. The MRI pelvis gave us a scar endometric nodule infiltrating the rectus abdominis and the uterocutaneous fistulous tract just seen. So hysteroscopy and fistulography done, which confirms the communication. And endometrial biopsy showed endometrial glands and stroma confirming scar endometriosis. The CA1 is quite mildly elevated and CBC and CRP was pretty much normal. So
how can you confirm scar endometriosis by endometrial biopsy?
No, ma'am, because what happened was they put a hysteroscope outside, and in a different center outside, they collected the sample from the, there was some tissue falling off the, this thing, ma'am.
If you do a biopsy from the scar endometriosis, it will show you scar endometriosis.
That is not our diagnosis,
from the endometrial cavity.
Yes, ma'am. There is not a diagnosis because they've said it's taken from the cavity, and how can you take a sample from endometrium and say it's endometriosis? It's not possible. So that is what we are diagnosing right now differently, ma'am. Actually, I'm just coming to that shortly, ma'am. So this was actually a uterocutaneous fistula due to scar endometriosis. Any idea of how we could manage this medical, surgical? Ma'am, maybe probably Dr. Vanita, ma'am, please.
Surgical and surgical.
Yes, ma'am. Any different opinions from anyone, ma'am?
No,
usually this is very clear
work.
cut because there's a fistula also. So you need to go to only surgical. If it is not a fistula and it's only a simple scar endometriosis, again there it will give you pain relief, but excision, wide excision rather, is the treatment.
So wide excision of the nodule plus removal of the fistulous tract.
That is I just want to tell you
that go up to the uterine wall and excise that area and suture it.
Exactly, ma'am. That's what we did. And the next pictures we have after this, ma'am. So once again, I think before
prior. You want these pictures? You want?
We had this picture here. This is how it looked, ma'am. After when we put a scope inside. So the entire uterus was plastered on top. We thought that the ovary might be stuck between the uterus and the anterior abdominal. That's what that's why we had endometriosis. What I had thought because she was operated for endometriosis before. But unfortunately, this is a picture, a scene. And then when we dissected, we found a huge tract over there. And the hysteroscopic picture below shows a small, I don't know if I can call it isthmocele because that happens post LSCS, but this is what we saw. So on the hysteroscopy, that fluffiness, what we saw over there is what we considered to be the probable isthmocele or whatever we can call for a myomectomy, which was done before. And Yes, ma'am. Yes. So that is where it was. That's why she was having some pain, and she had spotting also throughout the cycle. And this was a tract which was excised from the uterus. So, and then what else we did was excise the surrounding tissue around the tract on the uterine wall, and then suture in 2 layers, like how we suture an isthmosele. That's what is done over here, ma'am. And then this is what literature says. Medical management, vaginal analogs, and pain meds and NSAIDs. Surgical excision of the scar with the fistulous tract is what we did. They said putting on an omentum over the scar would be a benefit, is what they said. We didn't do that. Rather, we excise the entire tract and then suture in 2 layers. So, and then what we did is, in case we do this, if anybody could tell us any post-op or fertility preservation techniques to be followed, any delayed conception to be followed, what do you feel, ma'am? Any ideas?
Suppress this girl with GnRH, agonist or antagonist for about 4 months at least.
Yes, ma'am.
And the ovaries are so good. Why are you worried about preservation and all that?
No,
You
ma'am,
showed
I'm
us
talking
beautiful ovaries.
Future fertility is what I meant, ma'am, not preservation.
Future fertility, that's all.
She's already had a baby. Her ovaries are very good. And
No
there is
babies,
no
ma'am.
endometrioma.
No babies, ma'am. Nulli gravida. 7 years.
She had a cesarean section, right? No,
No, ma'am. She
No,
had a
myomectomy.
She had myomectomy.
No C-sections, no pregnancies previously.
Okay, she's
No
had a
babies.
myomectomy alone.
Yes.
That is why I didn't know whether to call it isthmosele or something else, because it was a myomectomy. That's why.
Can I move the slide?
Yes, ma'am.
So, see,
this
there
is
are,
what
I've had a cesarean, like a cesarean scar pregnancy. I've also had operated at Bangladesh. I had a patient who had come with a pregnancy at the myomectomy scar on the posterior wall near the fundus.
Yes, ma'am. So we advised her to undergo, use GNRH analogs for about 3-4 months, and then we sent her back and asked a review. She didn't come back, and then she came back 5 months later with UPT positive, and then she delivered a preterm baby by LSCS at 35 weeks, weighing 2.1 kgs. This is what happened. Any difference in opinions, if any of you want to give us, ma'am? Because again,
you are lucky that your patient conceived on her own, Ashwin.
And that is the best gift that we can expect, I think, isn't it?
True.
Yeah, we finished on all the cases, Dr. Jairani.
Yes, everything is done, ma'am.
Yeah.
I think scar
Thank
endometriosis
you.
prevention is most important. That should be really taught to everybody, especially the juniors who really start doing, not to use the same mop which they use to clean the endometrial surface over the rectus or the subcutaneous area, not to use the same suture material, second layer of the uterus again. These are things I think.
Ma'am, I think you're being muted.
And also retrieve the specimen in laparoscopy using only an endo bag when it's a chocolate cyst or an adenomyoma.
Yes.
Thank you.
Never
Even
allow that
clean the
to come
port
in
side,
contact with the
clean the port side with proper betadine, and even you remove it, that's also one important thing.
Yes.
Yeah,
Clean it
and
well. Even
whenever
if you
we are
open
having
with
like,
an endo bag, it's better.
a scar endometriosis, when we operate and it's a large defect on the rectus sheet, always consider mesh repair. You cannot always do a primary because that should be counseled. And if a patient is planning for further surgeries, that should also be there. It can be a little difficult to go in again for section. So that should also be told for the patients whenever we are planning. A bigger defect will definitely need a mesh repair. Otherwise, we are like, looking forward for an incision on you.
Yes.
Correct.
Then we have
last 1 or 2 slides.
Yes,
Agonist, antagonist cycle, many papers, yes, no, ultimately they say both are same. Though they said in the agonist cycle, the number of M2 oocytes were more, etc., but ultimately take home baby rate, it is same with either of them. Recurrent endometriosis case, we have already discussed, Dr. Ashwin has discussed. And studies on ovulation stimulation have shown no.
We have been a lot of time. I think it's better.
Last 1 or 2 slides finishing. Aggravation of symptom is not there. Acceleration is not there. And increase in the recurrence is also not there. One has to think of fertility preservation also in these women. I'm not going to go in detail in advanced cases of endometriosis. So this is the last slide. In the management of endometriosis with infertility, suitable tailor-made treatment option should be implemented without delay. Ultimately, fertility is the goal and objectives would be fertility restoration. However you do, relief of pain, another important thing, underlying disease should be kept at control and regular monitoring. So as all of you said, laparoscopy is the gold standard, respectful handling of the tissue, cystectomy in case of big endometrioma, and controlled ovarian stimulation with the IUI in early cases, direct IVF in cases of 3 and 4, and down regulation for 3 to 6 months prior to ART improves overall ART success rates. Thank you all for your time. Thank you, Dr. Ashwin. Thank you all the panelists, Dr. Richa, Dr. Desh Deepak, Dr. Umayal, Dr. Vanita, and Dr. Priya Kannan, and our esteemed judges, experts, Dr. Raki and Dr. Asha Rao. Thank you so much, Dr. Jairani, for giving me the opportunity, and to Dr. Ashwin also. Thank you so much.
Rekha and Ashwin, it was a wonderful panel, Rekha. You've done such a fantastic job.
Thank you,
I
madam.
like the way you moderated, and also the panelists are vibrant. So it was very interesting panel.
Enjoyed
And thanks to
being there in
Jairani
the panel. It
for
was
having
superb.
included us.
Thank you, ma'am.
Thank you, madam. Thank you so much, ma'am. Thank you, madam.
Thank you, madam. Thank you for
All
the
the best for the
opportunity.
forthcoming elections.
And at the outset, I would like to tell all my audience, if they are logged in, I am also standing for vice presidency. Please do remember me.
Yeah, sure, ma'am.
Thank you,
All the
Dr.
best, madam.
Thank you, Aruna.
Thank you so much.
Thank
I
you,
want to give a
Jairani, for involving.
formal thanks to all the chief
Yeah.
guest, Dr. Jaideep madam, guest of honor, Dr. Anju, Dr. Ramni Devi madam, Dr. Swarna madam, and also the senior faculties here, Dr. Raki madam and Dr. Asha Rao, for being the expert, and the speakers, Dr. Geeta Balsarkar, Dr. Subhash, and moderators, fantastic moderation by Rekha and Ashwin, and all the panelists here, Dr. Umayal, Dr. Vanita, Dr. Priya Kanappan, and Dr. Desh sir, and Dr. Suvita, Dr. Savita, and Dr. Richa, all being so enthusiastically joining us. And a very special thanks to all the chairpersons from the Jaipur, from Rajasthan societies, Dr. Savita Langia, who was there all the time. Thank you, madam. Thank you so much. A very special thanks to all the panelists, Umayal and all others. And a very special thanks to Sahiti for being with us, for giving us a nice platform for proper interactions. And a very special thanks to Sri Priya for coordinating everything. I thank you one and all. I really thank Sampath and Ramani madam for giving us a free hands to do this webinars every month. And also the Mumbai Obstetric Society and all the societies of the Rajasthan. Thank you so much. We look forward next month, third week again. See you all. Thank you. Thank you so much.
Thank you.
Good night, ma'am.
Bye. Good night. Good night.
Also standing for medical disorders in pregnancy for chairperson, requesting the presidents and secretaries to vote in my favor. It's an earnest request. Thank you for staying with us till the end of the program. Thank you so much.
Thank you. Thank you.
Thank you.
Thank you, Ashwin.
Thank you so much for the
Thank
opportunity.
you. Bye. Bye. Ashwin, see you on
Wonderful
Sunday.
case collection,
See you on Sunday
Thank you
in
so much,
Chennai.
ma'am. Yes, ma'am. Yes, ma'am. We'll be there, ma'am.
Discuss with Nimmi, whatever she wants, you both decide.
Sure,
It
ma'am.
is
Sure,
among
sure,
you.
sure. Definitely, ma'am.
Okay.
Sure.
Thank you. Bye.
Thank you, ma'am. Bye, ma'am.
Bye.
Thank you.
Thank you so much. Thank you. Bye, bye. Bye, Rakhi.